चेक चेक। और ये देखिए क्यों से कौन सा
check, check.
You look at.
To one and all present here. On behalf of Yashoda Hospitals, I am honored to welcome you all to the State of Art STEMI Care Conference. I am delighted to have you join us today to discuss the latest advancements and best practices in STEMI care. Throughout the day, we will explore a variety of topics related to STEMI care, ranging from fundamental definitions and diagnostic techniques to advanced interventional procedures and quality metrics. Our sessions are designed to provide you with valuable insights and practical knowledge to enhance your clinical practice. For me, it is certainly a distinct honor and privilege to be a part of and serve you as the master of ceremonies for this grand event. Today, we have gathered to discuss and explore the advancements in STEM care. Each session is designed to provide valuable insights into various aspects of STEM management, from emergency response to advanced interventions in cath lab. This program is scheduled in four phases. Phase 1, brief on STEMI, ECG, biomarkers, and multimodality imaging in STEMI. Phase 2, STEMI and emergency. Phase 3, STEMI and ICCU, which is followed by lunch. And lastly, stage 4, STEMI and cath lab. Along with all these stages, we have four workshops going on, which I'll update you as soon as possible. Now let's start with the first speaker of the day. I now invite Dr. Sumit Shedol, who is a leading cardiology doctor in Hyderabad, to guide us through the fundamentals of STEMI. Dr. Sumit has completed his MBBS from Government of Medical College, Nagpur. He has completed post-graduation MD from Government Medical College, Jamnagar, Gujarat, and he has done almost 7,349 plus cardiology surgeries till now. I invite you, sir.
On behalf of Yashoda Hospitals. To start with the topic of STEMI, we'll start with the definition. What is the definition of myocardial infarction? The first the feature of myocardial infarction dates to 1880s. The first definition, universal definition, from our purpose in late 1950s, the first time we found I defined the myocardial infarction and it was an ECG based. It was used for collateral to date, the field of used for epidemiological surveys. The biomarkers in the late 90s and early 2000s, the ACC and ESC, collaborator and redefine infection based on the clinical approach and the biomarkers. And with the development further services of the biomarkers, it was redefined again by Global Task Force in 2007 as a universal definition of myocardial infarction. And with the development of ultrasound sensitive markers and very sensitive markers, it was further redefined and reevaluated in 2012 and 18. So, we are about the third most automation in investing well. I just maintenance management structure, because of the demand supply was much. There is a microinfarction when there is there is no biomarkers. Either the development or they are going to infection is high some kind type 4 is just for the stage process and how the procedure. So I will see whatever changes, whatever is that I will added in the fourth definition permission. So the most important thing is fourth definition adds is a differentiation and so it emphasizes the use of stress, the use of cardiac MRI to determine the etiology of injury as well as velocity of angiographism suspected injury. There are certain updated concepts and there are certain new concepts, and also there are certain new sections that have been added with this declaration. So we'll see one by one. So it's a type of myocardial injury. So it is a detection of elevated cardiac troponin levels above the reference limit as a myocardial injury. There is a certain acute reason called as parameters. It is an acute sustained levels. It is a criteria for it is a so, account detected by the presence of abnormal biomarkers in the setting of evidence of acute myocardial. So, the evidence of acute myocardial is very important to define it as a myocardial infarction. This is almost about the lectures about differentiate so, it is a total spectrum where there are no there is no myocardial injury. With the myocardial levels, it is termed as myocardial injury. And this is present in the clinical evidence of it is associated with the evidence of clinical evidence of acute myocardial ischemia, it is known as myocardial infarction. So you can see all these different like heart failure, kidney failure, hypertension, shock, and hypertension, they all can cause myocardial injury as well as myocardial infarction. So to differentiate clinically on the basis of just the opinion is not possible. So we have to see the clinical context as well as the prevention of the patient. So the model for interpretation of myocardial injury and infarction. So there are levels of not just the single topic level, but the data that is the part of the topic level is important. So if the topic levels are stable, so the chronic myocardial injury that can be present in structural heart diseases like severe AS, severe MR, or PH, or chronic kidney disease. There was certain rise as well as followed by the fall of the cardiac troponin levels. But without the evidence of acute myocardial ischemia, it is acute myocardial injury, can present in acute heart failure, myocarditis, and any other cardiomyopathies. When it is associated with the evidence of acute myocardial ischemia, it can be a type 1 or a type 2. When it is associated with atherosclerosis or atherosclerosis, it is a type 1, it is either a plaque rupture or erosion. It is associated with the clinical evidence of sublime bronchial research. It is a type 2, which is there are multiple reasons, maybe tachyarrhythmias, hypertension, hypertension, anemia, and so on. So the quantitative work of baseline high sensitivity cardiac troponin levels. This slide is also important. So actually, exactly 19 reference limit is this is the which is the number of if I consider the number of that is considered as a reference limit. So those patients who are stable and going heart failure with supplemental disease, they have the levels which are either normal or slightly elevated levels. So, the elimination of cardiac problem, either it is 5 times, it is 10 times, or 10 times. It is very important in clinical context because differentiate between myocardial infarction type 1 type 2. It is very important to understand the absolute size of the cardiac problems as well. So if the values are 5 or 10 times, it is generally a micro level of myocardial infarction, medium myocarditis, embolism, shock, heart failure, hypertensive crisis, or subarachnoid bleed and chemotherapy. The lower acute conjugated India acute myocardial infarction, which is a medium to size myocarditis, maybe cardiomyopathy. And the levels are in the thousands. It is generally acute myocardial infarction or a severe myocarditis. Not just the same level, but also the delta is also very important. So we'll see how exactly that works. If we do the cardiac problem, the first 4 hours or we will do early sampling, we will see actual levels of the second sample. So it is that we should consider the clinical presentation of the patient and accordingly we should consider the time for taking the samples. If I don't have sampling, the patient presents with acute myocardial infarction. The first levels will be the present of up to 22% of the patient. They have the first drop levels normal if they present within 2 or 3 hours to the hospital. But if we do second levels after 6 or 8 hours, the second levels might be more than 1,000 or maybe 5,000 or 10,000. And as the time progresses, there is again a plateau. So we will get the data or the progress and the of the problems in the later part of the day. But towards the late stage of the disease, again there will be a little change in the level, and we will something also take sometimes to define it as a myocardial infarction. All about these definitions of type 1 and type 2. The most important things are at least one should be about 99% correct considered. Either the symptoms, series of this, or of loss of rival myocardium or identification of geography or during biopsy. Type 1 there should be awareness of imbalance between oxygen demand and supply supply. This is supply mismatch can be due to cardiac microscopic dysfunction or vasospasm, or maybe stab, or maybe it's just supply mismatch. So it's very important to understand the presentation of the type of myocardial infarction. Next, so whether the patient is emergency department, just or he is admitted to the hospital or the post-operative setting or he is in the ICU. So understanding the clinical context of the patient, whether it is a primary injury or it is whether it is secondary to other injuries or operations, it is important. There can be, and then according to the mechanism of the type 1, whether it is a pure supply reduction or a demand supply mismatch. Obstructive artery disease, it is because of this spasm or dissection or embolism, cardiac embolism, or maybe endothelial dysfunctions. Causing tachyarrhythmia of hypertension. Coronary artery disease, where the coronary artery disease guidelines. However, if there is no coronary artery disease involved, as severe hypertension, you don't have to treat the figures. Type 2 is very important. Here, the patients they have. But there is a suspicion as well as this is of the patient who are having myocardial ischemia. However, the fundamental diagnose myocardial infarction, that is they are non patient. So why know such a type? This is to differentiate the cases of fatal myocardial infarction who die within first few hours from sudden cardiac death. Sudden cardiac death can be cardiac or can be cardiac because of ischemic and non-ischemic reasons. So to differentiate between these fatal MI and sudden cardiac death type 3 is important. Then procedural myocardial injury. As I already told, in 2000s, when there was the first established definitions of myocardial infarction, and in 2007, they first came up with this 5 different types of myocardial infarction in 2007 with the at that time, initially it was thought that the top levels after the procedure, they are benign. Procedure means after CBG or post-PCI, the increase in the cardiac troponin was considered to be benign. But with the evidence that there as prognostic as before the procedure, the slight increase in the troponin, they were regarded as a cardiac infection, and obviously that made the interventional cardiologist angry, and there was a much debate in 2007 regarding the when to consider a procedure as a successful one and when to consider as an acute myocardial infarction post-procedure. So the alternate levels of the post-procedure, even a single, even if the basic level or the baseline levels are normal, then there should be increase in the normal baseline level of the baseline levels are already high, then there should be an increase of higher knowledge always it should be a stable or it should be not dropping better. And then we get more than 20% increase, we consider it as a procedural myocardial injury. For IVF, it is the post procedure within 48 hours with at least one value more than 5 times of the maintenance percentile. Which is our demonstration of the loss of value myocardial or myocardial. There should be an angiographic evidence to that. However, the ischemia symptom is removed from this definition, and if the values are not more than 5 times, we can term it as myocardial injury. For 4B, there is no change, but it's a either by or by autopsy findings, and it can be categorized as acute, subacute, late, and delayed depending upon the presentation. Type 4 says that is also sometimes due to the coronary angiography for a acute presentation of myocardial infarction, and in angiography you see that there is an instant restenosis rather than the thrombosis, or if the balloon angioplasty is done, then there is a restenosis of the balloon angioplasty. So this type of patients, along with if they increase in the cardiac troponin levels, this is a type 4 CMI associated with instant restenosis. Type 5 is after myocardial CMI, and it is more than 10 times increased over levels. However, the symptoms is removed from the definition now. So we see the clinical scenario where 50-year-old male was admitted for cardiac surgery. It is a major surgery. Cardiac evaluation before procedure is normal. Creatinine levels were 2.3, was given cardiac patient under in the procedure. Post surgery, the creatinine levels goes up to 4.5, and then patient complains of shortness of breath. Echo ECG was done, and that was normal, but the cardiac troponin levels were 400. So what is the next step that we have to do? Whether it is a myocardial injury or it is a myocardial infarction, the baseline levels in this case were normal, and I think we can think because there was no change, maybe normal or maybe abnormal. So what do we next do in such a person? Should we consider or straight away as myocardial infarction? Because the baseline levels in most of the laboratories is 20 in the gram. Here it is more than 400, around 400. So it is a many times elevation. So what is the next logical next step is to get the second troponin levels after 3 or 6 hours. After getting the troponin levels, suppose it is 420. So what is the diagnosis now? And what should be done for this patient? Because there is no 20% increase or because there is no significant increase in the troponin level after 3 to 6 hours. This is a scenario of chronic myocardial injury. It is because of the presence of CKD, the baseline CKD in the patient. So for this such patients, we do the shortness of breath is not because of the cardiac event. So same scenario, the comes as 2,500 milligrams. So now what is this presentation and what should be the next step? Here it can be an acute myocardial injury or as well as it can be an acute myocardial infarction. So we need to find the clinical context to it. So whether it is associated with the symptom or ischemia or whether there are CV changes or whether we or so in the we can term this as acute myocardial infarction. So myocardial injury, why we need to know what is myocardial injury is because up to 60% of the cases conditions where the high levels are up, and it is mostly because of myocardial injury. Patients who are present in hospital with evidence of myocardial injury, it is a concern prognosis with high fiber mortality. In the initial workup, without process for myocardial ischemia, there is no consensus regarding how to treat these patients. But the triggering factors or the precipitating factors is the most practical approach. Diagnosing type 1 is very important. These patients generally present with less chest pain and they more often have dyspnea and atypical presentations. Clinical distinction may be challenging, more often present in women, elderly, and diabetic patients. Elevated troponin levels, and there should be a rise and fall pattern with associated ischemia. If without ischemia, it is injury. these patients, they often have only small brains, so they have typical chest pain, typical ECG findings or imaging abnormalities. Further diagnostic evaluation is important. So we should quickly see what is the recurrent MI and what is the infarction. These two terminologies are first included in the definition. If the characteristics of MI after 24 days of the first event or incident MI, it is considered as recurrent. And if it occurs within 24 days, it is an infarction. For the infarction diagnosis, we should have at least 1 meter estimation done before the first levels or towards the approach in at least 2 continuous leads. Also, cardiomyopathy, this was also included. TPS can mimic the evolution of MI. It is found in approximately 1 to 2% of the patients who are suspected of MI. It is mostly triggered by the intense emotional and physical stresses. More than 90% of the patients are females. HT7 correlation is seen up to 44% of the patient, but it is usually beyond single coronary distribution. Even though it is associated with stimulation in multiple leads and severe early systolic dysfunction, the topic levels are not that high as in myocardial infarction. Usually, there is a modest increase in the topic levels, and angiographically, it is normal. Usually, see a recovery of myocardial function in within 2 weeks. This is also included in the definition. So, the diagnosis of pneumonia is made primarily after immediately after coronary angiography in those patients who are presenting with the features of myocardial infarction, but the angiography came out to be normal, because in critical stenosis, and the reason for the acute presentation. The important thing that this guidance or the definition stresses is that pneumonia should be considered as a working diagnosis. It is not a final diagnosis, and you should undergo a patient should undergo further evaluation find regarding the underlying mechanisms. So there are multiple mechanisms for it, starting from plaque disruption to vasospasm, dissection, embolism, myocardial, microvascular dysfunction, or supply mismatch. So how do you patient for because these patients are there are certain conditions that or stress or myocarditis or cardiomyopathy, they can be the situation of pneumonia. So in order to differentiate them, cardiac MRI is very important, and it is very important to assess the cardiac MRI as a first essential first step in the diagnosis of differentiate presentation. When you multiple patterns of it, ischemic pattern. The next presentation, Dr. Swapna, she will explain clearly regarding all these patterns. Just for summary, there are ischemic pattern and non-ischemic pattern. If it is transvagal, subendocardial, or propal subendocardial, it is ischemic pattern. However, if it is subcardial or wall, or if it has incision points on papillary muscle, it is a non-ischemic pattern. So these patterns are important. We can differentiate on the basis of these patterns whether the patient is having ischemic injury or non-ischemic injury. We have some patients at our center also who are presenting with the family the diagnosis came out with the myocarditis. So it is important to establish between the myocardial injury and infarction. High sensitivity dropping cells instead of conventional assays, is a working diagnosis. We should further evaluate and should not leave it at the diagnosis of pneumonia. Of CMR to differentiate pneumonia and pneumonia presentation is very important. Thank you. Thank you for your time.
Thank you, sir, for providing an in-depth definition and understanding of STEMI, emphasizing the critical nature of this type of heart attack. I now invite Dr. C. Raghu, Clinical Director and Senior Interventional Cardiologist at Yashoda Hospitals, Secunderabad, for briefing us about the ECG in STEMI.
It's Thank you for all coming on a Sunday morning to attend this acute MI session, total STEMI management. I thank Yashoda Hospital for making this happen, for providing state-of-art facilities. And we have a lot of 3 different workshops dedicated to interventional cardiologists. Namely, you forgot about the workshop and I sent you a WhatsApp message.
I invite cardiologists to join OCT and IVAS workshop in Auditorium 3. One of our staff members will guide you through the lecture hall.
Sumit, I think you can. Dr. Bharat Purohit will be taking care of the IVAS and OCT. Dr. Sumit Shejol is there. So somebody wants to attend the workshop on IVAS and OCT. We have dedicated workstations to learn about OCT and IVAS. So it would be a good opportunity when you have a teacher with a very small audience. I think that's the best place for one to learn about these new intravascular imaging, which can remain the cornerstone of practice as we go forward. So I will be presenting upon the myocardial infarction ECG changes, focusing on the ST elimination myocardial infarction. This has completely changed, huh? Connect my laptop. It's not. You are opening on WPS. This is not. Why don't you open a PowerPoint? Where is open on PowerPoint now? Just go on. You can put it on. So, model will be on ECG and ST elimination myocardial infarction. ECG, many times nowadays we have the advantage of having a automated interpretation by the electrocardiography machine. But having said that, if you know, there are a lot of advances on the electrocardiography also. So I have taken up those electrocardiographic advances. So in 2023, the European Society guidelines stop with the differentiation between ST elimination MI and non-ST elimination MI, but instead conglomerated both the entities and put up as a single entity called acute coronary syndrome. So the 2023 guidelines were on acute coronary syndrome. And as is characteristic of the EAC guidelines, they have put up a mnemonic for the ACS. And if you look at the mnemonic for ACS, A stands for abnormal electrocardiogram. So our fundamentally, when we start evaluating any patient with suspected ECS, you would go on to the ECG, whether the ECG is normal or abnormal. So the following bit, as Dr. Sunit was telling, the centrality of the clinical context. If the you should take the ECG or the taking into the clinical context as centrality. We can't interpret any laboratory investigation without taking into account the patient's clinical scenario. So the C stands for clinical context, and S stands for the stability of the patient. So, for example, you have a patient in the emergency room. You need to look at all these three parameters to further forward what we are going to do. And in this 2023 guidelines, what is the role of an electrocardiogram? So, an electrocardiogram should be recorded and interpreted as soon as possible with a target of less than 10 minutes. So within 10 minutes, one should update the ECG and come to a clinical diagnosis when the patient arrives in the emergency room. So this is the key. Then what is the role of electrocardiogram? An electrocardiogram is essential for us for not only for diagnosis, but also for risk stratification. So these are the two important. So the diagnosis as well as the risk stratification, these are the two main objectives for us whenever we see a patient with acute coronary syndrome. And here, if you can see in the guidelines, you have a working diagnosis, STEMI versus non-STEMI, that's or non-STEMI acute coronary syndrome. So this differentiation, your working diagnosis after the initial workup depends upon, once again, the major differentiation depends upon the electrocardiogram. So electrocardiogram is an important component for us to decide whether this patient has got STEMI or a non-STIAC. If it is a STIAC, you should go for a early invasive. If it is a non-STIAC, based upon the patient's clinical stability, you can go for an immediate procedure or a delayed procedure within the next 24 hours. So the guidelines have made it very objective and you will be able to take a plan of action quite easily. Now, what is the diagnosis, how to diagnose STEMI and the importance of identification of myocardial infarction and the vessel localization. Right now, if you are working on an incident or a cardiology resident, we should know how to diagnose the vessel at what is the culprit artery or the infarct related artery. So, what is ST elevation? It's very common for us to see an ST elevation and misdiagnose, especially if the person is young, them as a myocardial infarction as a suspected MI. So they have given in the latest guidelines what are the cutoff points at different ages and also a gender specific differentiation, especially leads V2 and V3. All the other leads, if there is a stimulation more than one or other in the absence of left ventricular hypertrophy or left bundle branch block is taken as a stimulation. And many patients with inferior myocardial infarction, I advise to all the colleagues to right-sided leads. Please start the right-sided leads in the emergency room, and you should also take the posterior leads to cover V7 to V9. So when you take the standing receiving of the posterior leads, whenever you should cover the right-sided leads. So that's nursing staff or the ECG technicians and also the residents have this electrocardiographic needs to come to the diagnosis. ST elevation myocardial infarction, acute MI diagnosis is quite easy, as we have already seen. That is very easy. You can see the top panel, you can see this type of ST elevation. I don't think we don't have the diagnostic error. But 90% of our patients come with a different type or an abnormal electrocardiogram. Then also you need to take send back the patient for cardiac cath lab immediately. Straightforward estimation is quite easy. But what happens is we have a posterior myocardial infarction. In a posterior myocardial infarction, you have a tall artery, vestibular depression, and you have got upright PO. So this STD complex of a ST depression with an upright PO with the complex of a upright TRS is diagnostic of posterior, especially lead V1 to V3. So I see a lot of times in the cardiologists also missing out a posterior myocardial infarction. It doesn't strike that right. So this is a very valuable panel from the latest ESC guidelines. We can see that if we have infarction, I will show you some ECGs also, where you have an ST elevation in V7 to V9, where the culprit artery is circumflex occlusion. So now as you go, so we need to identify this electrocardiographic pattern where the circumflex is not represented in any cardiography. So you have to take the posterior leads. Then, very commonly, we see multi-vessel ischemia. We have a lot of diabetic patients, chronic kidney patients, heart failure patients. Those are the patients who present with multi-vessel ischemia and left-hand coronary occlusion, where you can see an ST depression and the upright PO. So that is an AVR ST elevation. So this ST elevation or AVR and V1 with a normal ST depression, not into one coronary artery is a multi-vessel disease. Now, from APT of left bundle branch block. We were considering that left bundle branch block is a myocardial infarction issue, but not only for the 2013 guidelines, it is not a myocardial ischemia equivalent. But we should be aware that in presence of chest pain in clinical symptoms, and there is a high index of clinical suspicion, we should consider that LV has a high event rate. Similarly, RDM also has got a higher event rate. So when you have a clinical suspicion with a bundle branch block, either a right or a left, or a right, we should always consider that this gentleman or this person is having a ST elevation myocardial infarction to be considered. Similarly, lot of our patients can have non-ST elevation changes like isolated pain aversions or ST depressions or transient ST deviation. That means there is a dynamic. But these people do not have a significant thing. But if there is an ST depression, we have a worsen outcome. Similarly, I will show you Divinter sign and Brennan sign, which have been first time acknowledged in the guidelines. The Divinter and Brennan sign previously they were not acknowledged. Now they have been acknowledged by the guidelines, and they have been shown that they consider a proximal LAD occlusion or a severe stenosis. So Divinter and Brennan sign they should be rapidly shifted to the correct approach. Now, we all know this is a very landmark review article. The postgrad gives a bit to bring this article. How to localize the myocardial infarction and also anterior myocardial infarction. You can identify whether it is a right coronary, whether it is a right coronary, proximal right coronary, and if it is a left circumflex occlusion. So, we have these guidelines, which is very important for us, and we should keep it as a part of our. We don't think that only established L2 and L2, but we have to look at establishment L1 and L1. It is not one, it is n. So you should see that both of the parameters you need to look at it and go as per the algorithm. So, for example, say this patient who has got a chest pain and all of you can detect that there is a ST elevation in L1, AVL, L2, L3 and ADF. So you have got a infero-lateral. But what I would like you to recognize is the prominent R wave, some ST depression and an upright T. If you see an R wave in V2 and V3, you should always consider that there could be a circumflex occlusion. So this here in this artery, the circumflex is the culprit. So whenever you see some subtle changes here with a prominent R wave, it's a very important thing. Sometimes you might not see the classical ST elevation, but still a prominent R wave should always consider in the clinical setting whether it is a circumflex myocardial infarction. Similarly, for anterior myocardial infarction also, you can differentiate whether it is a proximal, that means before the diagonal or the mid or the distal, where it is beyond the diagonal, you can differentiate. And also you can differentiate whether the LAD is a wrapped up LAD. All of you should have this article and keep reviewing it, especially as postgraduates, as well as even now also I keep seeing this after so many years in clinical practice. So this is a patient where if you see, you can get a broad QRS in L1 and AVL and a notching in the L1 and AVL, and you can see D5 So all of us know that this is a left bundle branch block. So in the presence of a left bundle branch block, it is difficult for us to diagnose myocardial infarction. So you have to look at the previous electrocardiogram, which also shows some degree of ST QRS broadening, but the ST segment depression is not very prominent. So in the presence of a left bundle branch block, extremely discordant ST changes or a concordant. So most important is if the changes are concordant, that means the QRS polarity and the STT polarity are in the same direction, then we should consider it to be ischemia. That means, for example, in V2, V3, QRS is negative, ST segment is down. Similarly, so if you see this concordant ST changes, then you label it as ischemia. If there is discordance, then the discordance should be huge, that is more than 5 millimeters. Then we will consider it as ischemia. So previously we used to consider that left bundle branch block is myocardial infarction, not anymore, because we realized that LBD is more often a pre-existing marker of structural heart disease rather than acute ischemia. So but patients with LBD have increased mortality and more of heart failure, more sudden death. But this LBD is not necessarily due to ischemia, but due to a lot of ventricular changes which can occur in the conduction system also. So this is the algorithm which was proposed recently, where in patients with LBD, No or old, we do not know many times. If there is hemodynamic instability, then you should take them directly to the cath lab. If there is no hemodynamic instability, then you can look at the Zarboza criteria. If they are positive, then you go for the STEMI equivalent. If the Zarboza criteria are not met, then we can go for the biomarker serial testing, echocardiography to differentiate what is this one. So please do not come to the conclusion that LBD is STEMI. So LBB and reperfusion, how did the guidelines evolve? Initially, for all LBB, we used to think in 2007 guidelines, fibrinolysis a primary PCI. This led to a lot of unnecessary PCI. So that is why in 2013, LBB is not STEMI equivalent. And then now you have seen the criteria, the graph, what they have presented recently. That is the way how you need to approach the left bundle branch block. Now, I also appeal to all of you to look at this chest pain article, that is the critical decision pathways, emergency room clinical decision pathways, for evaluation and disposal of acute chest pain, how you can dispose of a patient in the emergency room. This is a very wonderful guidelines which have come up in 2022. We need to review them periodically so that we know which patient is high risk, low risk, and intermediate risk. I would show you, this is another patient which comes with chest pain. You can see that there is ST elevation in inferior leads. You can see a prominent R wave, ST depression, upright T wave. So inferior and posterior. What would you take next? You always need to obtain a right-sided lead. So V3R, V4R, also ST elevation is there. So that's a infero, postero, and RV infarction. So you need to understand RV infarction diagnosis is also very, very important. Now I would like to show you, this is the Wellen sign where you can see a T inversion in the anterior precordial leads. So this is you can have a typical T inversion like what you see here, which people will not have difficulty in diagnosis. But this is a type B, but we need to see this is the type of T wave inversion where we can see in some other patients where you can have a biphasic T wave inversion, that is a type A Wellen syndrome. So this Wellens is also a need for you to shift the patient to the cath lab immediately. So and this is a patient where you can have a ST elevation in inferior leads, ST depression in anterior leads. So for this patient, where is the culprit artery? Here you have got ST elevation and a global ST depression, and AVR there is no ST elevation. So what possibly you should think is this patient has an inferior MI but anterolateral ischemia. So this patient could be having a multi-vessel disease. So this is how you can see this gentleman has a right coronary as well as a multi-vessel disease in the left also. And this rhythm is where there is no PO and a fast rate. You can see this is the first ECG, this is the next ECG, then the broad QRS. This is a accelerated idioventricular rhythm or a slow ventricular tachycardia. This is also a common ECG pattern which you should recognize because this represents a reperfusion. In the latest one editorial, they have in JAC case reports, you can see these are all the life-threatening STEMI equivalent. It is not just a conventional ST elevation, but you should think of Deventer ST depression in a tall R T wave, ST depression with upright T wave, posterior MI, Wellens A, Wellens B, hyperacute T, Zarboza criteria, shark fin. This is, if you can see this, we had a patient yesterday or day before yesterday night, same classical shark fin type of ECG, very, very high mortality. This is acute ischemia in left ventricular hypertrophy. So this is a very interesting peak from JAC case reports recently. I will not go too much, but I would like to share with you, this is what is the what we call the Deventer sign, where you have got an ST depression and an upright T wave, and over time this Deventer did not have an ST elevation, but as you went forward, this patient developed a ST elevation myocardial infarction, a QS complex in V1 to V3. So Deventer is a rare STEMI equivalent. And finally, this is the final slide where what are the high risk patterns which we should recognize in a patient. If you see, this is a article which has come up in 2022. They studied about 1,800 patients with acute myocardial infarction. And let's look at the p-value. What is significant? Any person on the ECG, if the heart rate is more than 100, it is high event rate. Any patient who has got AFib on the ECG, that is high complication rate. Any patient who has got a QRS duration, which is more than 120, high event rate. Even a non specific intraventricular conduction defect, that means 80 to 120 also, it indicates that there is a higher event rate. So let me summarize. You have got a QRS duration, you have got an atrial fibrillation, and you have got a tachycardia. If these are there, they indicate that this patient has got a high risk ECG pattern on the ST elevation myocardial infarction. I think with this I will stop my presentation. End of this session, we will take some questions on biomarkers, cardiac MR, ECG. I think that would be good. Thank you. Thank you all.
The role of ECG in diagnosing STEMI, highlighting key indicators and interpretation techniques. Moving forward, I now invite Dr. Rathore, who is Group Head Laboratory and Transfusion Medicines in Yashoda Group of Hospitals, for sharing few words on biomarkers in STEMI management.
You. The topic which was given by Dr. Raghu earlier was biomarkers in STEMI management, but it was changed to role of high sensitivity cardiac troponin in MI management. So you are aware that there are multiple studies and guidelines, and the universal definition of myocardial infarction have emphasized on the usefulness of cardiac troponin in the diagnosis of myocardial infarction. 2021 guidelines for the evaluation and diagnosis of acute chest pain explained the need for HS troponin implementation as an additional support tool for the clinical acumen. In this acronym, you can see the A stands for high sensitive troponin, which is the preferable markers. So along with the clinical manifestations, signs and symptoms, cardiac biomarker HS-TROP is an additional tool in the diagnosis of myocardial infarction. So what are the advantages in implementing high sensitive troponin assays? One, it is having a superior analytical characteristics like detecting lowest level of cardiac troponin, measurement of highest level in dilution without any hook. It is highly sensitive and precise. What is meant by highly sensitive? It allows sex-specific cutoffs, possesses a low limit of detection, capable of measuring values more than 50% in both healthy female and male population with value greater than the limit of detection, and CV% is less than 10% across the measurement range. And it is validated rule in and rule out cutoffs, risk stratification along with algorithm, and this gives this assay a substantial advantage. In conventional troponin, the reporting unit is nanogram per ml. But to avoid the confusion, it is recommended in high sensitive troponin, the unit should be nanogram per liter. So like in the lowest detection limit in case of high sensitivity is 0.002 nanogram per ml, but it is reported as 2 nanogram per liter. The 99 percentile is 0.0035 nanogram per ml, but it is recommended as 34 nanogram per liter. And the upper limit of reporting of conventional assay may be lower than the current assay. So there are multiple platforms are available. So we must understand the certain terminologies and the usefulness of this biomarker. So the 99 percentile upper reference limit for the this cardiac troponin assay are derived by manufacturer from normal reference population. However, the methodology used to select the reference population varies across studies. HS level may vary significantly with sex and age, even among healthy individuals. Troponin levels are higher in men than in women and increases with age in both sexes. So this lowest quantification is nothing but a lower limit of a reportable value, and it should be invariably high than the lowest limit of detection. So what is the utility of high sensitivity in troponin uh, in the case of unstable angina? So is it the time for requiem for unstable angina? So we must understand how these biomarkers are released and how it is elevated in the serum. So after disruption of the sarcolemma of the cardiomyocytes, the cytoplasmic pool of biomarkers is released first in the serum, and the level rises above the upper reference limit immediately. This is followed by protracted release from the disintegrating actin that may continue for several days, and the cardiac troponin level rises 20 to 50% times more than the upper reference limit in case of acute myocardial infarction. So before 1930s, two manifestations, stable angina and acute myocardial infarction, were recognized. Patients in the gray zone between stable angina and AMI, that we now call unstable angina, were described 75 years ago and at first appeared to be quite rare. Over the next half century, they were recognized with increasing frequency, and by 25 years ago, about one half of all patients with non-ST elevation ACS were considered to have unstable angina. However, use of even more sensitive biomarkers of myocardial necrosis, especially cardiac troponin, has steadily chipped away at the fraction of patients with non-ST ACS without myocardial infarction, who therefore are still considered to have unstable angina. Dr. Von Walt, positioned in this article, stated in 2013 that in the next few years, there will be likely much more wider use of higher sensitivity assay like cardiac troponin and acceptance of the universal definition of myocardial infarction. So the unstable angina is likely to be further marginalized. So has not the time arrived to prepare a requiem for unstable angina? So unstable angina is decreased, but it is not extinct. Even in the contemporary trials, had a significant percentage of unstable angina patients are detected. Most of these patients labeled as unstable angina are not the low risk group, but instead are the intermediate risk group. These patients can be better risk stratified by the high sensitivity troponin testing. So it is important to note that despite improved sensitivity, in case of very early acute MI, the sensitivity is low. That is why the guidelines insist that if the patient presents very early in acute MI, we should not exclude MI based on single value. In fact, 10 to 20% cases of acute MI have a negative troponin value on arrival. This is the illustrated figure. Here you can see in very early presenters, it is hard to detect the delta value. In such cases, serial measurement after 2 to 3 hours is advisable. you employ, you detect more MI cases. The graph on the right shows the changes in MI before and after the implementation of HS drop based on the final diagnosis. Three categories of patients, type 1 MI, type 2 MI, and myocardial injury were segregated. Although the overall number of patients who showed an increased HS drop have increased, the maximum number is in those with type 2 MI and myocardial injury. Actually, the number of type 1 MI has decreased. So how frequently this decrease of type 1 MI occur? This depends on when, how often you choose to test for drop, and which patient you choose. The cutoff for HS drop is much lower in the US compared to the UK and European countries. This is a cohort study where you find that in the UK, you will diagnose more type 1 MI than the US, where you diagnose more myocardial injury. So those patients with type 2 MI and myocardial injury over a long term tend to have twice the mortality of type 1 MI, and these be recognized. Identifying patients with elevated HS drop helps us to recognize those individuals with underlying significant uh, coronary artery disease. Maybe an intervention at this juncture can help cardiologists to intervene early to reduce the risk at a later date. So this is the guidelines for measuring high sensitivity troponin based on class 1 recommendation. In patient presenting with acute chest pain, serial testing of troponin are useful to identify abnormal values and a rising or falling pattern indicative of acute myocardial injury. In such cases, high sensitivity cardiac troponin is the preferred biomarker because it enables more rapid detection or exclusion of myocardial injury and increases diagnostic accuracy. Clinicians should be familiar with the analytical performance and the 99th percentile upper reference limit that defines myocardial injury for the troponin assay used at their institution. With the availability of cardiac troponin, the role of CKMB and myoglobin are found to be not useful for the diagnosis of acute myocardial injury. So this high sensitivity cardiac troponin are increased in multiple conditions, right from myocardial injury related to acute myocardial ischemia, myocardial injury related to acute ischemia resulting from oxygen supply demand imbalance. Other causes of myocardial injury without coronary artery disease, either cardiac related or multifactorial systemic or indeterminate, like in case of sepsis, pulmonary embolism, and also in COVID. The false positive rates are very, very rare, and it is mostly attributed to pre-analytical stages. Troponin is cardiac specific, but it is not disease specific, a point which we must recognize. Although we identify many patients with elevated troponin, for the cardiologist, it poses a nuisance value and a diagnostic dilemma. This led to these troponin elevations being labeled as either tropanosis, troponin leak, and we need to recognize that even minor elevation of troponin is associated with increased adverse cardiovascular events. Heart registry showed that with the type 1 and type 2 MI, but without significant coronary artery disease, had very low mortality rates. Those with type 2 MI had substantially higher mortality rate of non-cardiovascular cause of death. Another European registry also showed similar data indicating coronary artery disease is an important driver for events. Even though there are no recommendations for performing additional diagnostic testing for in case of type 2 MI, it is essential to consider that ischemia as a cause is important. So over the period of time, there is a evolution in the algorithm of rule out based on the troponin measurements. So this European Society of Cardiologists guidelines have provided class 1 recommendation for the TROP since 2011. In 2020, European Society guidelines recommended 0 and 1 hour and 0 and 2 hour early rule out algorithm with class 1B recommendation. The recommendation also provides assay-specific risk stratification concentration thresholds that are helpful to the clinician. One has to understand, one has to note that the time of onset of symptoms should be more than 3 hours. So rule out is also having some problems or fallacy in some patients, like in case of renal failure or patients more than 75 years of age, as the rule out is challenges as they have slightly elevated troponin values. So even this high sensitive troponin is implemented very late in US, but still over a period of time there is a increase in the implementation of this SCV, high sensitive troponin. Sensitive troponin impact diagnostic testing in emergency department. The data from Mass General and Mayo community indicates that despite the implementation of high sensitivity troponin, the rate of subsequent diagnostic testing remained the same or slightly reduced. So the concentration of HS troponin is directly proportional to the severity of myocardial infarction or myocarditis. The broader differential diagnosis associated with lower range elevation of HS troponin begins to narrow as concentration increases. So what is the way forward? So knowledge transfer, collaboration and educations are crucial for implementation of in transition to novel HS troponin assay within the stakeholders. So this is the algorithm for transition to high sensitivity cardiac troponin testing. That is what we have just discussed. So the transition to HS troponin should be universal for all services within the institution. In a hospital, to reduce ambiguity and to attain substantial advantage, only one marker has to be implemented, because the harmony between the conventional and the high sensitivity troponin is not perfect. So to conclude, high sensitivity troponin offers substantial advantage for the early evaluation of patient with possible acute coronary syndrome. Education and collaboration are necessary for successful implementation of high sensitivity troponin protocols. Know your assay and use a validated acute coronary syndrome troponin algorithm. Clinical evaluation in addition to high sensitivity troponin remain critical for further assessment. So thank you for your attention.
The significance of biomarkers in the management of STEMI, detailing how they guide diagnosis and treatment. I further invite Dr. Sapna Marda, consultant radiologist, Yashoda Hospitals, Secunderabad.
All. At the outset, I thank Yashoda Hospitals and Raghu sir for giving me this opportunity. Radiology, cardiac imaging, by itself, it is a subspecialty in radiology now. And coming to cardiac MR, I can say that there are many radiologists who don't know to read a cardiac MR. So also, I believe it would be in cardiology department, except for few experienced ones, it would be really not everyone is used to seeing the images of cardiac MR. Radiology, it is basically different shades of gray that range from black to white. We try to see those images and interpret them. There are some shades of, there are some colors in between, but most of it would be shades of gray. what I have done is I've taken 6 cases wherein the cardiac MR has helped in diagnosis and management of the patients. So, yeah. So to begin, what is the role of cardiac MR? So MR helps in looking at the cardiac structure. We can look at the wall thickness and say whether it is thinned out or it is thickened. We can see what is the wall, is there any wall motion abnormality? How is the function? The ejection fraction that we get through a cardiac MR is much more accurate than a 2D echo. And cardiac MR helps in assessment of myocardial perfusion, rest, and even stress perfusion. It not only helps in diagnosing an acute myocardial infarction when there is a diagnostic uncertainty, it also identifies what is the culprit vascular territory. We can see what is the area of infarct, how much is viable. We can give a scar percentage on cardiac MR. We can also, it is also useful in giving the differentials of myocarditis or Takotsubo cardiomyopathy. MR is the gold standard for assessment of LV thrombus. We have seen cases where 2D echo was not able to pick up LV thrombus, but cardiac MR was able to pick it up. And MR has also role in global and regional LV function post-MI patients. We can see microvascular occlusions in these patients, which is a bad prognostic sign. And coming to MINOCA, MR has a particular value in establishing a diagnosis in patients presenting with a working diagnosis of MINOCA following invasive angiography. Now, coming to the 6 cases, I begin with the first. This is a 69-year-old patient who is already a known case of coronary artery disease. He had inferior wall MI, was already stented. Now he came with history of left-sided chest pain and shortness of breath. He presented to an outside hospital where in ECG they found that there was ventricular tachycardia. He was given some medication, was put on antiplatelets, and then sent for further management to our hospital. When we looked at his past history, we saw that there was PTCA done to LCX, PTCA was done to RCA, and also there was a recent 2021 angio which showed that there was complete RCA, proximal RCA occlusion. There was LCX patent stent. Now, when we evaluated here, the patient had a high tropi in the range of 7,900. The pro-BNP was also elevated 1,500. 2D echo showed that there was akinetic basal inferior, hypokinetic mid-inferior wall. So inferior wall is involved having regional wall motion abnormality. So we are thinking that RCA territory is abnormal. Now coming to this angio, you can see that this patient has significant stenosis of the LCX. LAD looks more or less okay. There's no significant stenosis in the LAD. Only proximal RCA is opacified, rest of the RCA is occluded. So the cath diagnosis was a double vessel disease with proximal RCA occlusion and LCX significant stenosis. And the proximal LCX was well opacified. Now coming to this MR, first we look at the regional wall motion abnormality. So here this is the anterior wall, this is lateral wall, septal wall and the inferior wall. I hope the cursor is visible. Is it visible? Yeah, thank you. So you can see that there is significant thinning of the inferior wall. The rest of the myocardium is contracting, but this myocardium is not contracting. So there is akinetic inferior wall. Even in this view where we have this long axis view, we can see that the inferior basal to mid cavity wall is very much thinned out and it is akinetic. And you can see even some areas of dyskinesia. So then we have followed it up with post-contrast MRA, delayed. We do a delayed scan. Whenever there is a case of viability, what we are looking, if we are looking for viability, what we do is this basic 2D basic images where we look for the wall motion abnormality. Then when we give patient contrast, that is gadolinium, we take images at around 7 to 8 minutes and then we also take it at a later time, that is around 15 to 20 minutes. Every hospital has a different protocol. In our hospital, we are following 8 minutes and then 15 minutes. So what we see is that scarred myocardium takes the gadolinium within. So whenever you see enhancement, it is most likely to be either it could be fibrosis because of the scarring. So in this case, you see that this is the dark myocardium, which is in jet black, is the normal myocardium, whereas here there is no myocardium seen. The normal myocardium has to appear jet black. When it is appearing bright, that means it is abnormal, it is scarred myocardium. So this scarred myocardium is seen in the inferior and the inferoseptal wall, in the basal cavity, in the mid cavity. How do we identify mid cavity? We look for these papillary muscles. So at the level of papillary muscles, it's going to be mid cavity. So in this image, you can see that from the basal to the mid cavity, the inferior wall is appearing white, that is showing scarred. So only the inferior territory was infarcted, that is RCA territory, whereas the LCX territory was viable. So this patient was taken. Now this cardiac MR helped us in saying that the LCX territory is viable, and hence the patient was taken for angioplasty of only LCX. Now coming to the second case, this is a 32-year-old gentleman. He presented with chest pain. He was admitted and he was diagnosed as anterior wall MA at a local hospital. Outside CAG was done, which showed that there was a single vessel disease, which was LAD, that was 70 to 80% thrombotic stenosis was given. Then he came to our hospital for further management. Now, when we look at this coronary angiogram, the LAD looks okay. There's not much of disease, maybe some mild narrowing here, but there is no significant stenosis, as they have mentioned that 70 to 80% stenosis. So then this patient underwent a cardiac MR. So if you see here, the lateral and the anterior wall is okay, but here here at this level, if you see, the interventricular septal wall is thinned out. We will see it again once again. So here it is nice, whereas if you see the septal wall, it is relatively hypokinetic. And then when we have done a delayed contrast image, you can see, I hope you can appreciate this, that there is some bright signal, convex curvilinear bright signal at the level of anterior septal wall in the distal cavity and the basal cavity, in the distal cavity and the mid cavity. So this is the four-chambered view where you can see that this is the interventricular septum. Less than 50% of the thickness of the septum is appearing bright. So whenever the septal brightness or the enhancement is less than 50%, we take it to be a viable myocardium. If the thickness is more than 50%, or if it is more than 75%, definitely non-viable. If it is between to 75%, then we also look at the regional wall motion abnormality. So this patient, if we see, there is endocardial, subendocardial enhancement. See, the terms what we use is it a mid-myocardial enhancement? Is it a subendocardial enhancement? Or is it a subepicardial enhancement? Everything has a different value, meaning, so whenever there is a subendocardial, especially that ischemia, it starts from the subendocardial level, then goes to the rest of the mid-myocardium and later becomes a transmural infarct. Here you are seeing only that there is a subendocardial enhancement, and that too, if you see here, it is less than 50%. So there is scarring, but it is less than 50%. So the LAD territory is viable. So in this case, MR helped us in saying that yes, even though there was 70 to 80% stenosis, there was 70 to 80% stenosis, but by the time patient came, there was no thrombosis. That maybe there is a spontaneous recanalization. So this patient was put on long-term antiplatelets. Now coming to case 3, this is a 45-year-old male patient. He presented with chest pain, diagnosed as anterior wall MI. He had high troponin. So you can see that it is in the range of 22,600. Echo showed there was akinetic apex, hypokinetic septum and anterior wall. So there is regional wall motion abnormality in which territory? Apex, septum and anterior wall. It suggests that there is LAD territory. So there was a left ventricular apical clot. If you see this angio, there is some 78% stenosis in the RCA. You can see here that there is stenosis of the RCA. Here there is osteoproximal stenosis of the LCX. Here there is osteoproximal stenosis of the LCX. And look at this. This is very interesting. If you see here, this is the LAD. This is the proximal LAD. There are good sized diagonals here. But the proximal LAD, after this diagonals, you are not able to see the mid-distal LAD. So there was occlusion of the mid-distal LAD. So this patient had triple vessel disease. Patient was sent for MRI. MRI shows that there is hypokinetic interventricular septum. This is at the level of mid-body. I can see papillary muscles. As I go from the mid-body towards the distal cavity, the myocardium has become thinned out and it is almost hypo to akinetic. Now, this is the delayed post-contrast scan, wherein I can see that there is transmural enhancement of the apex. And as I go, I can see that towards the distal cavity, there is involvement of the septum. Part of the anterior and the inferior wall is involved. As I go towards the basal cavity, it is subendocardial enhancement, but it is more than 75%. So this part of the LAD territory is non-viable. Please look at this area. See here, if you can see, this is the basal anterior wall, which is dark. Basal anterior wall, mid anterior wall. So the anterior wall is appearing black. That means it is viable. So part of the LAD territory was viable, but mid distal part of the LAD territory was occluded. The same thing is again represented here in the fourth chamber view. You can see that there is bright here enhancement. So you are seeing the apex and the interventricular septum is scarred, whereas only the part of a anteroseptal wall and part of the basal wall, anterior wall is viable. Also, I want you people to look at this image. You can see that there is a left ventricular thrombus. You can see this as a filling defect here. So, as I said, MR is the modality of choice when we were looking for LV thrombus. So, we have given this as non-viable part of the LAD territory except for the basal anterior wall. And now with correlation with CAG, we know that why the proximal basal part is viable. It's because of the proximal LAD and the diagonals, good sized diagonals. So the distal LAD was non-viable and hence we avoided revascularization of the LAD. Now coming to case 4, this was an elderly patient who presented with acute heart failure. He had atrial fibrillation with fast ventricular rate. Troponin was mildly elevated around 22. His pro-BNP was elevated, which was 765. On echo, there was dilated left atrium, left ventricle. There was akinesia of the apex, hypokinesia of the inferior septal wall. And also there was involvement of mid and basal inferior wall. So taking into this, you know that LAD territory, that is apex, septal and anterior wall are involved. Because mid and basal inferior wall is involved, it is RCA territory. So there was clinically, there was suspicion, ECG, echo-wise, there was suspicion of vessel involvement. But the patient underwent outside CAG, which said that there was LMCA with triple vessel disease. We don't have the CAG images. Patient was sent for cardiac MR. Here we can see that there is some hypokinesia of this septal wall, especially in the basal cavity. As you go towards the apex, the ventricle appears more or less okay. All the walls appear okay. So even if you look at the diameter of this left ventricle, you see that it is dilated, especially this wall is showing hypokinesia. So we have done a post-contrast enhancement. If you can see here, there is enhancement. You are not able to see the dark myocardium. It is only seen only in the outer portion. So more than 75% thickness of the myocardium is showing enhancement, especially in the basal to mid cavity. So more than 75% thickness enhancement from basal to mid cavity involving the inferior wall. So it is only RCA territory infarction. But if you see at the LCX territory or because there was even the LAD territory, there is no enhancement. So the LAD territory is viable. Only part of RCA territory was non-viable. Hence, MR helped in planning revascularization. This patient was sent for CABG. He has underwent CABG and is now doing well. Now, these last two cases are very interesting. These are this is a 20, till now what you have heard is you already know. See, MR is useful in cases of to know the viability. Whenever there are multiple territories are involved, you want to know which territory is already infarcted. You would avoid that territory and you would revascularize the territory which is still viable. Now, these are two cases are a little different in that this 29-year-old gentleman presented with retrosternal chest pain. ECG showed that there was ST elevation in lead 2, 3 and AVF. Troponin was in the range of 11,000 and BNP was normal. 2D echo did not show any regional wall motion abnormality. So if you see here, I think you people can better interpret ECGs. So you can see here there is ST elevation in lead 2, lead 3 and in AVF. So clinically there was diagnosis of probably there could be some inferior wall MI. This patient, we have done a CAG here in our hospital. And if you look here, LAD looks okay, LCX looks okay, and the RCA looks okay. So at least you know that there is no significant stenosis in any of the 3 major vessels. So they have given CAD insignificant, probably a Prince Mitchell angina or a recanalized RCA was that. Then patient was sent for cardiac MR. If you look at the cardiac MR looks, the regional wall motion abnormality, there's no regional wall motion abnormality. You can see ventricle is contracting well. You can still again see the images again. Sorry. Hang in the ma. So what happened is this patient had only just mild interventricular septal hypokinesia. That's it. Otherwise, the motion there was no regional wall motion abnormality. Sorry for this. On doing a post-contrast MR, what we saw was how many, except for maybe for the senior cardiologist, other than them, how many of you have come across cases of Minoka, especially the students or the residents who have come here? Have you come across cases of Minoka clinically? Provisional diagnosis was clinical diagnosis was Minoka, and how did you evaluate those patients? Can anybody see your experience? So we came across such cases. There were 2 to 3 cases we have come across, wherein we saw that go to the next slide. రావట్లేదు. క్లోజ్ చేసి ఇంకొకసారి ఓపెన్ చేసేసారు అది. Thought that it could be Minoka, basically myocardial infarction with non-obstructive coronary arteries. So we came across 2 cases wherein we thought one case was just, it could be MI, but it turned out to be. Sorry for the technical glitch. I have to go to. So the coronaries were normal in this case, or there was no significant disease. They gave it could be either a insignificant CAD, query principal angina, or recanalized RCA. So if you see at these images, there's some hypokinesia of only the basal septum. Otherwise, rest of the myocardium is contracting well. There is no obvious dyskinesia at other levels. This is the delayed post-contrast images. So what we can see that there is white signal, that is transmural enhancement in the inferior septal wall, part of the inferior wall. And if you can observe, there is some enhancement even in the inferior wall of the right ventricle. So this corresponds to RCA territory. So there was infarction in the distal part of the RCA, in the part of RCA territory. Not only that, we also observed that there was some subendocardial enhancement in the basal anterior wall. There was some near transmural enhancement in the lateral wall. So there were three different territories. So I discussed with Raghu sir. He said, good, I'm not able to come to a conclusion, sir. There are three areas that are involved and you say that CAG is normal. Then he said that it could be because of coronary spasm. And this was later, because of this, he was treated as antiplatelet. Was given antiplatelet therapy. So this is a case of Minoka wherein there was elevated tropi. The ECG, including echo, was normal. There was no regional wall motion abnormality. There was no significant disease in CAG. But MR could detect infarct and diagnose it as Minoka. So here comes the role of MR in patients of Minoka. Now this is another interesting case. This is a 36-year-old male patient. He also presented with left-sided chest pain. If you look at his tropo, it was elevated. It was 3,400. ProBNP was normal. Echo showed some mild hypokinesia of the apex. Other than that, there was nothing significant. CAG was done. CAG also did not find anything abnormal. So you can see that, sorry. But the CAG was normal. There was no significant disease. So clinical diagnosis, provisional diagnosis was it could be Minoka. So then the patient was sent for cardiac MRI. And if you see at the cardiac MR, there is normal movement of the myocardium. There is no regional wall motion abnormality. And then we did. If you look at these images, this is a stir or a fat suppressed image where if you see the rest of the myocardium, if you compare the inferior wall with the rest of the myocardium, this is appearing little bright. We call it as hyperintense signal. And even in the T2 weighted images, if you see this myocardium, this is all black. Whereas this bright signal with little thickening is the abnormal area. This is hyperintense. So we did a delayed post-contrast, and this post-contrast image showed that there is enhancement here. So the enhancement, if you look at it, it is subepicardial extending to the myocardium. You can see in this image, the epicardium, subendocardium is spared. So there is a subepicardial to mid-myocardial enhancement with sparing of subendocardium, I'm sorry. So once we know that endocardium is spared, it is unlikely to be ischemic cause. It has to be something else. So it is either an infective or inflammatory cause. We diagnosed it to be myocarditis. So here in this case, a patient was put on regular medical management. So this is a case of Minoka, which helped, cardiac MR helped us in differentiating it from infarction, that it was not infarction but myocarditis. So just a few words about Minoka. It is the criteria for diagnosis Minoka is acute myocardial infarction, coronary angiograph showing no significant stenosis. It should be either less than or equal to 50%. No alternate diagnosis. So now European Society, American College of Cardiologists, they suggest that whenever there is a clinical provisional diagnosis of Minoka, the patient should be further evaluated with CMR because it helps in confirming or at least ruling out the diagnosis. So the most differential diagnosis of Minoka, the causes are probably either a plaque disruption or coronary vasospasm. As in our case, we were suspecting it could be coronary spasm. It could be either embolism, thrombus, spontaneous coronary artery dissection, or microvascular dysfunction. So the coronary microvascular dysfunction is the hallmark of the all Minoka subtypes. This is another article which was recently published. They have done a follow-up of 252 patients who were provisionally diagnosis of Minoka. They were followed up for almost 10 years. Here, they were first cardiac MR was done, and then they have seen that in more than 50% of the patients, cardiac MRI ruled out Minoka. It was the enhancement or the pathology was not infarction, but it was either myocarditis or non-ischemic cardiomyopathy. Only in 25% of the patients, it was myocardial infarction, and in the rest, it was normal CMR. It not only helped in diagnosis, but it also helped in prognostication. If you see at this graph, with years on the x-axis and major adverse cardiac events in the y-axis. If you see a patient having a normal cardiac MR, this orange one is the normal cardiac MR, has less risk of major cardiac events. But if you look at the patients with myocarditis or myocardial infarction or non-ischemic cardiomyopathy, the risk of major adverse effects is much higher, especially it was more for non-ischemic cardiomyopathy. So thus CMR not only helps in diagnosis but also in prognostication. So we have seen 6 cases. One case was double vessel disease where RCA LCX was uh, involved, which was showing significant stenosis. MR showed that only RCA was non-viable, so LCX was revascularized. The second case, patient had single vessel disease. It was already recanalized by the time patient had presented to us, but MR showed that there was subendocardial infarction, but still the territory was viable, so patient was only put on medical management. The third case was a triple vessel disease where the LAD was non-viable, so there was no revascularization done for LAD. Fourth patient was a patient with heart failure with triple vessel disease. Only part of the RCA was non-viable, rest of the territories were viable. So he was guided for revascularization and he underwent a CABG. Last 2 cases were those of Minoka, where in one case it confirmed that it was Minoka, and in the other case it was said that it was not Minoka, it was actually myocarditis. So now cardiac MRI, as I said, it is a subspecialty by itself. Not all radiologists know to interpret. We are also in the learning process. And thank you so much to our cardiologists who give us this opportunity. Because of the discussions we have with them, we get to learn a lot. Thank you so much, sir. Thank you for the opportunity. It's teach and learn. Thank you.
Thank you. With Dr. Rajkumar and Dr. Sapna for this session on diagnosis of acute myocardial infarction. We covered the various facets in the diagnosis of acute myocardial infarction. We opened this session for discussion and for diagnosis on troponins, new STEMI definition, and also on the MR. And you can understand like centers like Yashoda, where with the availability of a multimodality imaging, how we collaborate with our radiologists and label people with different diagnosis. Otherwise, most of these patients are on dual antiplatelets for life, labeled as myocardial infarction. But instead, when we start doing the MR for all these patients, we know that the diagnosis might look, what is the point of diagnose myocarditis and all, but it makes a lot of impact on the patient. We have a clear-cut diagnosis of MI versus myocarditis or MI versus non-ischemic cardiomyopathy. So it makes a lot of difference for the patient and the management plan. And implementation of high sensitive troponin, how we can go forward in implementing across the hospital, involving all the stakeholders. Dr. Rajkumar has taken up, and Dr. Sumit had nicely spoke about myocardial injury versus myocardial type 2 MI versus type 1 myocardial infarction, and how to make a modern definition of myocardial infarction, and how we can implement into our clinical practice. I would encourage people to ask questions with the eminent faculty being here, so that we can understand how we can replicate these practice patterns into our day-to-day practice. Yeah.
Congratulations, all speakers have done well. This is regarding Rathod. Can you give more details? What exactly the 99 percentile of mean, that is?
So 99 percentile means
Normal is higher is 14 nanograms is normal. What is exactly 99 percentile?
so
Present with just when with the ST depressions, he comes with 15 or 13 nanograms. What did it mean?
it means it rule out if there is no clinical symptoms or other findings.
Presented with chest pain and depressions and elevations showing 13 nanograms. What does it mean?
Yes, it means it on arrival, even though it is below the upper reference limit, then after 2 hours or 3 hours, as per the algorithm, we have to do the serial testing. And most importantly is time of onset of symptom is very important. This high sensitivity troponin starts early, but if you do the serial testing, the difference you have to note it. If in the lower range, the difference you have to note it is in absolute terms. But as the concentration increases, you have to note the difference in a relative term, that is in a percentage.
So what is exactly the mean
I will explain you, sir. So, for example, all of us, troponin is a marker. But for example, you and I also will have elevated troponin because I am at a different age and somebody else is at a different age. The troponin will remain in the circulation. But what is the normal value? For example, ejection fraction, what is the cutoff point? Previously, we used to take 60%, but with the advent of MR, we take it as 53%. So, similarly, for the biomarkers are not elevated beyond for that means 99% of the normal population do not have the elevation of troponin. That is the reference number. So that number is taken as 14 now. So anything beyond 14, that means it is a abnormal. That means 99% of the people will have less than 14. That is what is the 99th percentile. If anything beyond that 14, we consider it to be elevated troponin. So that is what is the 99th percentile. For example, we take 90 percentile, let us say. So 90 percentile means possibly you might have to take the cutoff point at 7 or 9. So some of the people, even though they are normal, they still have a mildly elevated troponin. But we cannot take it because if we become more and more lower, you will be able to pick up minor elevations of troponin, which could be considered as normal. But if it is beyond 99, that is considered to be pathological. So what is happening is, for example, going forward, if you have a cardiac health checkup, a normal person, you say that your lab cutoff point is 5, and you have a person who has got a trop of 9, then it indicates that this person over the next few years might is at risk of having increased event rate. So that is how we should look at the troponin. It is a gradation, a minor elevation to more than 14, to more than 50, to more than 100, like that. So below 14 also you can take some value. So initially was 21 was the cutoff point, if you remember, that became 14 now. So 14 is the 99th percentile for our population.
So yes, this is regarding the fifth class.
Sir, here I want to add one thing. This 99 percentile, that is 14 nanogram per liter, is not fixed. It is assay specific.
Yeah.
What platform you are using, different platform is having a different type of cutoffs. It ranges from 14 up to 50 also.
So the assay what we use, whether it is a Siemens or Abbott or Architect, determines what is the cutoff point for our particular laboratory. That is why all the clinicians should be aware what assay, what machine they are using in the laboratory.
Madam, the case Minoka, case number 5.
Company to company it varies.
Also, it is sex specific.
Gender specific, it is also age specific also. For example, somebody is 65, their troponin might already be about 20, but you might not consider it to be pathologic.
So this is regarding Minoka, the case number 5. What is the information you got after doing MRI, sir? What is the information you got to this?
There was infarction. So there was an insult.
Case number 5.
Case number 5, that young patient.
Minoka, normal coronary arteries.
Yeah.
And what is the...
So basically, sir, that patient had ECG changes. He had chest pain. He had tropi elevation. Okay. But the CAG was normal. So there was no significant disease. So clinical diagnosis was of Minoka. And when we did MR, it proved that there was infarction. So he had Minoka. Basically, he had infarction. So he cannot be just discharged. He had to be put on long-term antiplatelets. Whereas the next case, the 6th case, which was a young patient also presented with chest pain, he had tropi elevation. CAG was normal, but MR did not show subendocardial enhancement. It showed subepicardial to mid-myocardial enhancement, which we see in cases of myocarditis. So the treatment for myocarditis would be different and the treatment for infarction would be different. Right, sir? Raghu, sir?
Raghu, sir, the 5th case, the MI and treated and included normal coronary artery, sir, and the scar is there and no obstructive lesion. What's the additional thing we are providing help to the patients?
Yeah, it's very, very important for us because what happens is we do not, the echocardiography was normal for this patient. Echo is normal, ECG is minor change, and when we do coronary angiography, it is normal. That means what you considered as myocardial infarction does not have any evidence of myocardial infarction except for the elevated troponin. So if you look at the first topic, the definition of acute myocardial infarction is elevated troponin plus 1 out of the 4. So it could be either coronary angiography or ECG changes or whatever is those one out of the 4. So when you have troponin elevation and the cardiac MR is showing a scar, that scar, is it an ischemic scar versus a non-ischemic scar? So if it is a non-ischemic scar, there, for example, a 32-year-old person doesn't need to take antiplatelets for life. So it has got lot of, for example, a 30-year-old person, you label them as myocardial infarction, he has to be there on medication for a lifelong term. So we can avoid that. And people who have got, as you can see, scar and no scar on the MRI. No scar on the MRI, they have a good survival. If they have got a scar on the MRI, even though they do not have coronary artery disease, they are going to have an increased event rate. The scar can be either ischemic scar or a non-ischemic scar. So it is important for us that all patients who come to us with troponin elevation is not necessarily ischemia. It might be, it is cardiac, but in the cardiac, it could be due to multiple reasons. So that is why now you see atrial fibrillation associated elevation troponin. How do we interpret? So now we are going into a field of in a timeline of cardiology where we need to use our brain a lot. Gone are the days where you just focus on the angiogram and put a stent.
So, sir, this is regarding the same fifth case. So the antiplatelets are used to prevent the
Recurrence.
formation of thrombus in the coronaries.
Yes, sir.
So coronaries are normal.
Yes.
What is the need for going for platelets?
Yes, sir, that is what you have rightly pointed out. So when you have coronary surge normal and there is a subendocardial ischemia is there, then it indicates it's a ischemic heart disease. So ischemic heart disease, as we all know, patients with ischemic heart disease have got a higher chances for the recurrence of cardiovascular event rate. So as a secondary prevention, you 100% give antiplatelet drug. For primary prevention, you will not give antiplatelet drug. So for a patient who already has got an ischemia, for secondary prevention, you can use statin, antiplatelet and all. For example, for a myocarditis patient, there is no role for putting them on a lifelong statin, antiplatelets and labeling them at a higher risk for event subsequently and all that.
Thank you.
So it's a very interesting phase that all our top elevations is not MI, and that top elevation could be either ischemic or non-ischemic, identifying them using a cardiac MR and starting, and madam has told that we have seen 5 or 4 Minoka and she did not specify the timeline. We saw in 2 months time. Last 2 months only, because what I am trying to say, these are the things which are evolving. Like in you saw in 23, you got the Minoka guidelines come. We started implementing in the practice. It takes some time. Convincing a patient for a cardiac MRI after a coronary angiogram is a big task in our country. So they have to pay, they have to stay 1 more extra day, and then they have to wait for the report. And then we say that, oh, your diagnosis is not myocardial infarction, it is myocarditis. That fellow will think, why did you do the angio for me?
Thank you, sir.
Thank you. I think with this, Dr. Navneet.
Thank you, sir. Let us now go ahead with phase 2, STEMI and emergency room. I would like to call upon Dr. Malaya Kumar Mishra, Senior Consultant and HOD, Department of Emergency Medicine at Yashoda Hospitals, Secunderabad, to guide us through the same.
like to thank Raghu sir and the management of Yashoda Hospital for giving me the opportunity. So this is a very interesting topic. Once we receive the patient in emergency room, and before that, what has happened to the patient, in what conditions we receive the patients, everything I'll be including. So as all of you know, this cardiac arrest and heart attack, these terms we often interchange very frequently, but these are not same. So heart attack happens when the blood supply to the heart is blocked, and subsequently the blood supply to the blocked artery will have less blood supply, and subsequently the tissue will be damaged and there will be necrosis. In case of cardiac arrest, basically when the heart stops beating, it will be a malfunction of the heart, having some irregular heart rhythms. They will have arrhythmias. So the sudden cardiac death is basically it's a electrical problem, whereas heart attack is a circulatory problem. So if we are not sure, many of the times we have to call, depend upon the emergency response system, and there's a group series of things involved here. There's a called multimodal approach. So we need to identify the person is having cardiac arrest. There is no pulse. There is no BP. That is the first thing we need to work on. That is early recognitions. Immediately after witnessing, we have to start the early CPR. That is the next link. We need to start this early CPR because in pre-hospital scenarios, this is what we need to work more on this. Second, after doing these interventions, we need to go for early defibrillations, and subsequently, patient need to reach to the hospitals for early percutaneous coronary interventions. So what happens when there is no pulse, there's no BP, and the patient is pulseless? So we need to start this CPR. So I am here right now focusing for high quality CPR. It is basically of 5 things. One is push hard, push fast. The rate should be 100 to 120, and the rate should be 100 to 120, and depth should be 5 centimeters and 2 inches. We should have proper allowed chest to recoil. Many of the times it is lacking. Third thing is you should avoid excessive ventilations, and minimize the interruption time should be less than 10 seconds. So these are the things we need to work while delivering the high quality CPR. Subsequently, the patient land off into emergency room, and our main priority is to stabilize the ABC, airway breathing and circulation part. Once the patient reaches to the emergency room, we need to obtain a ECG. The timeline says it should be within last 5 to 10 minutes maximum time. Then after obtaining the ECG, depending upon the ECG evaluations, whether it is a MI, ST elevation MI or non-ST elevation MI, we need to alert this STEMI, it's code STEMI, and after that, everything will fall into place. We will involve our cardiologist. The treatment plans, what all of you know, is fibrinolytics, because in these days we are going for primary PCIs, and subsequently patient is having triple vessel disease or left main coronary occlusions, we may go for bypass. So it's a complete disturbances when we will have patients suffering from coronary artery blockages. Basically, ST elevation MI caused by complete blockage of the coronary artery, as I said, disrupting the blood flow to the heart muscles. Subsequently, there will be rapid tissue damage, and the blockage leads to rapid cell death in a large portions of the heart with potentially life-threatening consequences. So we need to have an urgent need for treatment that is will restore the blood flow to the minimize the damage to the heart muscles. Coming to this epidemiology part, little bit widespread of prevalence is there. Study shows that the chest pain affects almost 3 to 7% of the Indian populations, with higher rates in urban centers among those who are having risk factors like dyslipidemia, diabetic being the most common cause, obesity. Then leading cause of death will be ischemic heart diseases like myocardial infarctions are the major contributors to the burden of chest pain. Subsequently, they will be having economical burden for the society, and it including lost productivity, increased healthcare utilizations, and reduced quality of life for those who are affected. Recognizing the signs and symptoms, as all of you know, chest pain will be the first and foremost things. They will be having sudden intense pain, discomfort in the center of the chest. Sometimes patient will be having breathing difficulty. They will be having feeling of tightness or pressure around the chest, and that might differs from the female gender, because many of the times they will have certain onset of dizziness, unintentional tiredness, fatigue. So we should not ignore these kind of symptoms, and subsequently there will be associated of sweating, there will be profuse sweating, there might be accompanied by clammy, cold clammy extremities. So after going to these signs and symptoms, we need to do like rapid identification by doing a ECG. That is a must thing, that is time sensitive, because where every minute counts towards the restoring of blood vessels. and minimizing the heart muscles that are dying. So we need to activate this code STEMI, or in pre-arrival setup, we need to activate the emergency response system so that as soon as possible, the patient will reach to the hospital where the PCI facility is available. ECG acts as a diagnostic tool, as all of you know. ST elevation SEMI, that's like we need to pick up that thing. If the patient is having signs and symptoms, is having profuse sweating, breathing difficulty, we need to have a proper interpretations and activation of the code that will better help us in treating the patients. So after obtaining the ECG, as in the previous speakers have already mentioned, we need to localize the infarctions, which artery is involved. Suppose it's anterior, inferior, or posterior. Anterior being the most common, inferior is the most dangerous. So we need to look on that by doing this ECGs. We may have to see some kind of Wayland sign, type A, type B, Deventer signs, or Garbosa criteria, because these are the classical findings we will not see in a regular ECG practices. But yes, of course, whenever there is a ECG changes, we need to have a look on this particular thing. And in the pre-hospital scenarios, basically the oxygen administrations being the first and foremost thing when the paramedics will able to provide, and we need to have a measure oxygen level by monitoring in the and suppose someone is having an oxygen level of less than 94%, we need to provide by supplemental oxygen by mask or nasal cannula, and titrate the oxygen values, saturation above 94%. Then after that, we need to have ask for aspirin, because there's a person, many of the times there will be hypersensitivity. It is not common, but it is still there. So we need to ask the patient to take aspirin that prevents the further blood clot and formations and reduces the risk of myocardial infarctions during a STEMI event. So the doses, basically it's a 325 mg chewable tablets, and aspirin should be chewed and swallowed to ensure rapid absorptions. It should not be withheld if the patient has already taken a dose. Make sure we need to give aspirin. That is the first thing. Second, if the patient is having pain, we need to assess the pain, because evaluate the patient's level of chest pain and discomfort. It is very, very essential. And after that, if the person is having severe pain, we may have to administer morphine, that is opioid analgesics. And after giving morphine, we need to closely monitor the patient's vitals, because many of the times patients will be drowsy and the patients will be in comatose conditions. So we have to take care of airway as well. And after giving morphine and pain control, we need to consider for the patient to transport, rapid transport, because we need to minimize that time interval. And many of the times in rural areas, we can have this ambulance setup. And in basically in the marine areas, like we can have this helicopter facilities where the patient can reach to the hospital as early as possible. After reaching the hospital, this STEMI code and PCI enable facility for the immediate intervention to restore the blood supply. So the role of pre-hospital care STEMI management includes critical in the prompt recognitions, diagnosis, and initiation of life-saving treatment for STEMI patients. By stabilizing the patients, administering initial medications that includes aspirin, morphine sometimes, rapidly transporting them to the nearest PCI capable facility, the pre-hospital teams can signify improve the outcomes and reduce the time to definitive care. So this was a classical findings here, like in this traditional way of approach. When the patient is in ambulance, we can get a ECG done in the ambulance itself. After that, it will be transmission by the social network, and we can send it to the emergency room physicians who are sitting over there, and they can interpret, and the patient can be ready for the primary percutaneous interventions. But this is the era of AI. So now it has come into the picture. It is be having mini portable 12-lead ECG devices installed in ambulance itself. So that will be transmitted to the central processing unit as AI center internet, and the AI will interpret and give the feedback. Ultimately, the patient will have a reduced time, and the patient can directly proceed for the cath lab interventions. Thank you so much for patient listening.
Thank you, sir, for guiding us about the strategies and protocol for managing STEMI before the patient reaches the hospital. I now invite Dr. Shashikesh Srivastava, Senior Consultant Interventional Radiologist at Yashoda Hospital, Secunderabad.
PCA after fibrinolysis. The answer is obvious here. We do PCI for nearly every patient after fibrinolysis, but why? Why fibrinolysis? Subsequent slides will show us the extent of spread of fibrinolysis in the country, but when a patient with STEMI comes first contact, first medical contact, and the delay is less than 120 minutes or something, the results of fibrinolysis and taking for primary PCA are nearly similar. Now, we all know most of the population in India don't have immediate access to a cath lab or PCI capable center in the first 120 minutes after, onset of chest pain. There's many of our patients have delay in seeking treatment. That's a patient delay. Then emergency medical service delay. And then once they reach the hospital, the diagnosis. So from the point of first contact, it's already a significant delay in time where you are in the 2 to 3 hour period where fibrinolysis will help salvage the myocardium before we further go ahead. Now, if you see here, these are sorry. So the previous this is a slide taken from 2017 guidelines. Point of first medical contact, STEMI diagnosis. If it is less than 120 minutes, directly go for primary PCA and take less than 90 minutes for reperfusion and wire crossing. If it is more than 120 minutes, fibrinolysis strategy is indicated. Now, after that, if it is a PCI capable center like ours, immediately take for PCI, and PCI should and wire crossing should be within 60 minutes. Now, what does the new guidelines have said? All the things remain same, but after after fibrinolysis, immediate transfer to a PCI center, or either for primary PCI if it is less than 120 minutes, or for early PCI if it is after 120 minutes. These are the guidelines, and we will see why these guidelines have come into the picture. Now, this slide will tell us what state we are in. This is the time from median time to primary PCA. Normally, we talk of 60 minutes, we talk of 90 minutes, but here in India, the time duration is nearly 20 hours. So if you accurately identify the time when the patient has symptoms and you take for PCA, the average time is nearly 20 hours compared to European countries, less than 5 hours. Even there, it is nearly 4 hours. So time delay is very important. And that's where we need to do fibrinolysis because of the access problem. Now, even for fibrinolysis or thrombolysis, the average time taken in Indian situation is nearly 6 hours, wherein thrombolysis becomes lesser and lesser effective. Now, so ideal time less than 60 minutes for lighting or less than 90 minutes for PCA. Once that is done, you need to look at the pathways, rescue or ischemia driven or routine PCA. Let's see the evidence for each of them. Now, why time matters? In the first 3 hours, you see this, even from the ACC guidelines, there is no preference for either thrombolytic therapy or PCA if the MI patient has accurately presented within 3 hours of onset. Most of the patients coming from periphery, if they send us the ECG and tell us what should we do, we tell thrombolyze and then send, or if it is less than 120 minutes, we tell send directly. Now, what is the evidence for this? This Prague 2 tile, CAPTIM tile, Vienna registry, these have all shown that within 3 hours, in the early hours, thrombolysis is as good as primary PCA, the cutoff being 3 hours. Now, if thrombolysis is good enough, why do we leave it at that, and why do we think of PCA? Now,
Fibrinolysis achieves normalization of flow, that is TIMI3 flow. TIMI is the frame count that we do in angiographic frame count in only 50% of the patients. So if you thrombolyze 100, the adequate blood flow in the culprit artery is seen only in 50% of the patients versus 86 to 89% in those who undergo primary PCA. So thrombolysis only 54% have TIMI3 flow. Primary PCA has 80 to 90% TIMI3 flow. That shows primary PCA is more beneficial. And why is TIMI3 flow important? The benefits of thrombolysis are more pronounced if TIMI3 flow is achieved only. Whether you do primary PCA or thrombolysis, TIMI3 flow determines the outcomes. And the other risk only with only fibrinolysis is reocclusion after successful fibrinolysis is nearly 13%. So 13% of patients will have re-MI after fibrinolysis. So this is some examples of from different trials which have shown varying rates of 1.8 to 8.8% with re-MI after tenecteplase, streptokinase, tenecteplase. So in spite of using all these drugs, the re-MI is nearly 8 to 10% or 13% on an average. So obviously only fibrinolysis is not sufficient. Then how do you diagnose failed fibrinolysis? So what are the ECG markers? Most of us know this 50% resolution, but the actual one is 50% resolution of ST segment elevation in anterior leads and 70% in inferior leads at 60 to 90 minutes. So when you give a lytic agent and you check at 60 to 90 minutes, if the resolution of ST segment is less than 50 or less than 70 in inferior leads, it indicates failed thrombolysis. Apart from it, you can also do it from the add all the ST elevations and then divide it also. The patient may have persistent chest pains and electrical or hemodynamic instability. These are all signs of failed fibrinolysis. Let's look at this. Now, these reperfusion criteria about are also very vague, and if you don't diagnose them, you unnecessarily delay the PCA. So if the resolution of symptoms are there, then the median time from fibrinolysis to angiography in this study was 22 hours. But if there is persistent elevation, you take the patient early for PCA, thus salvaging the myocardium. So the criteria are not really decided it. Now, why do we do routine early angioplasty after thrombolysis? Because lysis is not the final step. We have seen in the preceding slides that it is only 50% effective. There can be re-MI, and hence we need to open the vessel completely. And that's why the concepts of early PCA after thrombolysis has come. Now look at these slides. Routine early PCA is green, and this shows that compared to standard treatment, early PCA decreases the occurrence of endpoints. So when you do early PCA after thrombolytic therapy, the outcomes are better. Now, the other important point about the thrombolysis versus PCA is whenever you do thrombolysis, as time increases, the benefit decreases rapidly. So you do it thrombolysis at 3 hours, the benefit may be good, but at 6 hours, 8 hours, 10 hours, the benefit decreases rapidly. The same is not true for PCA. Even if you do at you can salvage better. Even if patient comes at 6 hours, 7 hours, the benefit relative to thrombolysis is more with PCA, and hence you need to do primary PCA or early PCA more often. Now, so within 12 hours, still primary PCA can be possible. Otherwise, thrombolysis can be successful. Now, based on these, we have now two pathways. Delay is very less primary PCA. Delay more, we do what is called pharmaco-invasive strategy. This can include rescue PCA based on some evidence which we'll see later. Now, this is a good slide in that it will tell us what are the different types of PCA immediately following MI. Let's look at primary PCA immediately done, simple, good. If you can't do that, let's look at it. What is facilitated PCA? Facilitated PCA is you are in a PCA capable hospital where there is access to cath lab, but you still thrombolize and take patient immediately to cath lab. Now, that sounds interesting because you have two modes of revascularization, but the outcomes are not good. What are the studies? Ascent 4 and Finish. We look at them. There they have shown increased worse outcomes. So facilitated PCA has gone out of favor nowadays. Now, what is this Ascent PCA? In this, the immediately within about 110 minutes, PCA was done after thrombolysis, but the patients had increased bleeding. Now, there are two reasons postulated for this. One is that they were not adequately preloaded with antiplatelets. Two, GP2B3A and all were not adequately given. And also in the immediate fibrinolysis period, there is increased chance of prothrombotic state because of degradation products. So platelet activation and aggregation are heightened after thrombolysis. So if you take the patient immediately for PCI in that, there is increased chance of thrombosis. So this is a negative trial. Ascent 4 is a negative trial. Similarly, in Finnish style also, there was major bleeding rates occurring with the facilitated PCA. So facilitated PCA has gone out of favor. Now, what is it? Rescue PCA. Rescue PCA, where, if the patient's ECG has not settled and symptoms are still there, you take up the patient immediately after thrombolysis. And the evidence for that is rescue trial, Merlin trial, React trial, all these favors rescue PCA. So rescue PCA also favors outcomes. Now, the other thing is, now the patient has come successfully out of MI with the successful thrombolysis. What do? Do you do routine? And if routine, when and how? Now, whom? The answer is obvious in everyone. When and how we need to look at it. Now, routine early angioplasty after fibrinolysis. This was studied in this transfer AMI trial, wherein they were randomized, nearly 1,000 patients were randomized to routine angioplasty ischemia driven versus rescue or early angioplasty. The median time to PCI was nearly 4 hours, range of 2 to 6 hours. In this study, they were all given antiplatelet therapy and GP2B3A inhibitors as and when required. The rate of cardiovascular events at 30 days was significantly lower with this so-called pharmaco-invasive therapy. So thrombolysis done, early shifting to PCI capable hospital, and then early angioplasty. Now, there is a wealth of evidence for this. So this is again transfer AMI trials among high-risk patients who had myocardial infarction who were treated with fibrinolysis. Transfer to PCA within 6 hours after fibrinolysis was associated with lesser ischemic complications than standard treatment. Again, this is another trial, CARES AMI trial, where many patients were these days are given in periphery abciximab of Riopro with in this abciximab was given, retiplase was given in half dose, and then the patients were transferred to PCI capable hospital. This was also a positive trial wherein within 6 to 24 hours PCI was done. It showed better outcomes. This meta-analysis again showed routine early PCA within 24 hours of thrombolysis for acute ST elevation myocardium. It offers better outcomes. Now, this is again a pharmaco-invasive, another study where pharmaco-invasive approach is safer and more offers better than facilitated PCA. So, this resulted in ESC 2023 guidelines with some evidence that early angiography with subsequent PCA is recommended standard of care after fibrinolysis. Now, when? The question is when. The patient may come from periphery, the patient has been thrombolyzed a few hours before. What is the ideal time? The ideal time has been described as 2 to 24 hours after thrombolysis, after successful lysis. So, this is we saw even in the transfer AMI trial that around 4 hours is the average time delay for taking up for PCI after thrombolysis. So again, various endpoints like death, reinfarction at 6 to 12 months are favorable in terms of early PCI than with standard therapy. So now the algorithm has changed to primary PCI. Okay. Otherwise, if thrombolysis is successful, early PCA after 3 to 24 hours of first medical contact. This has come into the guidelines. Now, more evidence for it has come in the last few years during COVID times, where the patient comes. By the time we do COVID tests, we don the PPEs and all. So there, most of the times the patients were thrombolized, and then COVID test was done, and then the patients were taken up for PCA. Most of them had good outcomes. Now, the other question, do all these trials and most of the time, clopidogrel was the second antiplatelet used in all these trials. So, but is there any evidence for ticagrelor? Yes, this TREAT trial showed even ticagrelor is safe with ST elevation MI after pharmacological thrombolysis. So patients who had received fibrinolytic therapy in the 24 hours before randomization were excluded in Plateau trial, which is the landmark trial for ticagrelor. So between the 2013 to 17, there was some lacuna in data about whether you can use ticagrelor immediately after thrombolysis when you are taking for PCA. Now this TREAT trial has answered that question, and there is no increase in bleeding immediately after thrombolysis if you use ticagrelor. Again, prasugrel, another strong antiplatelet. Here also, within 24 hours, you can switch from the clopidogrel to prasugrel and do primary to PCA. So I'll end it with the guidelines based on the weight of evidence that we have seen now. ESC ACS guidelines have said rescue PCA is recommended, and it is class 1A, and transfer to PCA capable center immediately after thrombolysis is again 1A, and angiography and PCI culprit artery or infarct related artery should be done between 2 to 24 hours after thrombolysis. So all these three have class 1A recommendations. So any doubt about what do you do after thrombolysis? Immediately refer to a PCA capable center. And when should we do it? Between 2 to 24 hours, we can take up for PCA. So the algorithm is fibrinolysis, early transfer, rescue PCA based on criteria for failed thrombolysis, or routine early PCA within 24 hours. So in the circumstances that we have in our society, with where fibrinolysis is more easily accessible than primary PCA, fibrinolysis can be life-saving and muscle-saving. But we should understand that's not the end point, and we should early transfer the patient early to a PCA capable center where benefits of complete revascularization will help the patient in the long term. Thank you.
I keep seeing lot of times patients being kept after thrombolysis in the hospital, considering that there is a risk of transferring the patient after a successful thrombolysis. But means during transport, if something happens, there is a medico-legal risk for the primary doctor. So how do we address that apprehension in the mind of the doctor?
Probably we may have ambulance equipped with basic support like a defibrillator or ventilator, and the chances of immediate post thrombolysis risk are negligible. I mean, except for arrhythmias, which we can manage. IC bleeds, if they happen, there's nothing we can do. But a capable ambulance delivery system with defibrillator can help.
Okay. Then one more thing is, for example, we want to assess the how successful is my thrombolysis. How long should I wait before I say, and based on what parameters I should say my thrombolysis has been successful or unsuccessful?
Yeah, we probably have to wait for 60 to 90 minutes, sir, based on the guidelines, because that's when we define whether the thrombolysis is a failed one or a successful one. If the ECG elevations have not reduced by even 50% in anterior leads and 70% in inferior leads, that means it's a failed thrombolysis. Also, if failed thrombolysis mandates urgent referral to a PCA capable center. So probably 60 minutes is the time when you want to keep the patient and shift to a PCA capable center.
Yeah.
Sure. Thank you. So done wonderful thing. This is regarding the peripheral issue, sir. What is your view giving aspirin along with ticagrelor for thrombolysis, sir? What is your comment?
Yes, sir. Aspirin plus ticagrelor for thrombolysis is now indicated and it's standard. We can thrombolyze the patient.
So it has to be given only clopidogrel for the thrombolysis or
No, sir.
ticagrelor for PCI. It's not.
No.
So if the patient, if
Ticagrelor can be used.
So
That treat trial and all, they have shown benefit for ticagrelor.
sir, there is another issue, sir. If the issue is not possible to transfer the patient to PCI after fibrinolysis, the patient is non-responsive in 30 or 60 minutes, can we try tirofiban in that context, sir?
Yeah. No, sir. That is not recommended. Rethrombolysis is not recommended. GP2BB 3A for failed thrombolysis is also not recommended, sir. The only option is early transfer to a PCA capable center.
Sorry, sir. We have tried to many occasions. We had successful, sir.
Okay.
So we do streptokinase because we work in the small station. Though we have lab in our place because on and off we may not have facility to get the interventional cardiologist. If there is any issues, we have seen the success of pain relief as well as ECG reversal after giving tirofiban.
We are leaving things to chance in that situation. One. Second, guidelines do not support it based on the available evidence. Things may happen. See, many patients may survive without with spontaneous recanalization, without thrombolysis or without primary PCI also. But combining thrombolytic with GP2B is definitely taking chance and definitely higher risk of bleeding. And repeat thrombolysis with half dose that was also practiced is again to be avoided, sir.
So, thank you, sir. Thank you.
Sir, I would like to understand how long will you wait before you start your 2B3A?
30 minutes, sir.
30 minutes. So I think that is one, that's why I was asking the question. As per the guidelines, if the patient does not respond also, wait for 60 to 90 minutes. That's what the slide is showing. So it is important learning for all of us, how long we should wait. So within the 90 minutes, if the patient doesn't get a complete relief of chest discomfort also, we need to counsel the family that it will take about 60 to 90 minutes. End of 90 minutes only, we will say whether the patient has responded or not responded. Then one more, this one, there is in the 2023 guidelines. For example, you have a patient who is going within 120 minutes to the cath lab, not for the fibrinolysis arm. So if the person is not receiving fibrinolysis and directly going to the cath lab, so the latest guidelines say that you should give a single antiplatelet agent. And the second antiplatelet agent has to be given at the time of coronary angiography. So the life has, for people like me who are in practice for a long time, initially we were giving one antiplatelet agent, and then we were waiting for the coronary anatomy, and then decide on the second antiplatelet agent. Then came double antiplatelet agent in 2017 and 2023. Once again, we have one antiplatelet agent and second antiplatelet agent again. So from 7 to 23, in the last 16 years, we have seen the life running the full cycle.
Thank you, sir.
Yeah, thank you, Rishi. Thank you. One more thing, Dr. Komineni has told about Minoka. So I just was trying to recollect. The Minoka is a working diagnosis. So once a person has got a normal coronary after a acute MI, we should always do further workup. It is not a final end diagnosis for the patient. So we have to tell them that you need to get a cardiac MR. So we might say that in Guntur, we don't have cardiac MRI, Chalkalurpat, we do not have cardiac MRI. But I think once we start understanding the knowledge, you will invest in a cardiac MRI soon.
Thank you, sir, for addressing the role of PCI following fibrinolysis in STEMI patients. Further, I invite Dr. Kiran Kumar, Assistant General Manager, Quality Assurance, Yashoda Group of Hospitals, to guide us through quality matrices in STEMI care.
Before they keep on this slide, I will ask Dr. Shashikant. When do you recommend a 2-3 session in acute MI? As a part of primary PCI or as a part of the pre-hospital transfer? What is the role of GP2B3A?
Post thrombolysis?
For primary PCI, post thrombolysis, pre-transfer to PCI, post PCI.
First rule for any doctor is do no harm. So if that is the principle, then post thrombolysis, it is better to avoid a GP2B3A inhibitor. There have been innumerable cases of CNS bleed when you give thrombolysis with 2B3 inhibitors, especially if you land up in a trouble with an intracranial bleed and the patient goes to court. There's nobody to save you. There's nobody to save you because it's against the guidelines. So do not use 2B3 inhibitors unless you're planning an intervention on the cath lab table. In that situation, we give small boluses of 2B3 inhibitors. And that's it. We don't give an infusion, especially if you're given streptokinase. It's a systemic fibrinolytic agent. It's a very powerful drug, very severe effects, and the effects last for almost 24 hours. So those patients who are receiving streptokinase, please do not give 2B3 inhibitor. Number 2 point, if you're giving tenecteplase or alteplase, they are fibrin-specific thrombolytic agents. So these drugs have their effect gone by about 2 to 6 hours. In that situation, if you are not finding a benefit, again, probably a short bolus of 2B3 inhibitors will be helpful. But by this time of 6 hours, your clopidogrel has already started working. Your aspirin has already started working. And almost 80% of the antiplatelets effect is already on. So again, the role of 2B3 inhibitors in the periphery is on the lower side. Third important point, if you do not want to thrombolyze a patient, okay, do not thrombolyze, but you would like to give a 2B3 inhibitor in the periphery and ship him to the cardiac center, that is also a fair decision because you can give him a small bolus of eptifibatide or tirofiban, put him on an infusion and ship him to a cardiac center. That would be the better way rather than giving a thrombolysis, especially STK and then a 2B3 inhibitor. It's a deadly, dangerous combination. I think one should avoid that. Whatever your experience, but once you go to the court of law, you're finished.
When projects after window period, sir?
So up to 1 hour, 3 hours or 4 hours, thrombolysis still works. But beyond the window period, the best mode of opening up the culprit vessel is angioplasty. Best mode is angioplasty. The faster, the quicker, the better. So get him onto a vehicle, shift him to the cardiac center, get the vessel opened as fast as possible because thrombolysis is not going to work at that time. The effect decreases with time.
The patient presents after window period, after the patient is MI, after 12 hours presentation. Can we try with the tirofiban?
Yes. See, your antiplatelet agents, clopidogrel and aspirin, take a little time to act. Aspirin starts its action. If given sublingual, probably you get an action in about 1 hour's time. Ticagrelor, if given crushed, 2 tablets crushed, again in about 60 to 90 minutes, you have almost 80% to 90% antiplatelet efficacy done. So these drugs are very good. But in case you feel your drugs have not reached the system, and you're sure the patient, you've given the tablets and the patient is vomited, you're not sure he's reached this. In that situation, you can give your tirofiban or eptifibatide IV, because you're going to get a direct antiplatelet action. Vomiting would not have disturbed that IV route. And in delayed presentation, you can give a tirofiban and eptifibatide and ship him to the hospital. Again, late presentation, the best option is angioplasty. Raghu, your comments.
That's what I wanted to ask Seshi also. Seshi is here? Yeah. Seshi, so what is the time gap, Dr. Komini is asking, what is the time up to which you can thrombolize a patient?
In one of the slides that I showed, the efficacy of thrombolysis comes down rapidly once you cross that 3 to 6 hours period. So if you're crossing 6 hours, unless you have no other option, primary PCI up to 12 or even beyond up to 24 hours is a better option, because the benefits of PTCA and angioplasty do not decrease as rapidly as the benefits of thrombolysis. So 10 hours after thrombolysis, after presentation, thrombolysis may not be at all effective, but PTCA, we may still do a good job. So one of the slides, up to 12 hours, you can still call primary PCA.
One more important thing is, if there is an occluded infarct related artery after 48 hours.
There is no guideline says
it is class
no.
3.
Class 3. We should avoid that.
We should avoid
48 hours.
48 hours. After 48 hours, opening up the artery by PCI is going to be deleterious. So we should not try to open the artery. It's a red.
A very good afternoon. Thank you so much for giving me this opportunity, and especially to Dr. Raghu sir. And it's my honor and a privilege to share dais with other eminent faculty and the clinicians. I'm here to talk about quality metrics in STEMI care, like how these quality metrics will improve the outcomes of the STEMI care. So it's important that to have a successful program should have a continual quality improvement process, which will actually define the outcomes and the care delivery process. So why quality metrics for STEMI? Why it is so important? The first is to improve patient outcomes. So these quality metrics usually that assesses and improve the quality of care delivery, and in turn they will actually help in defining and improving the interventions for the clinicians. Benchmarking care. Benchmarking care means benchmarking the hospitals and the clinicians with the best available standards, okay, and internationally and internationally. And it's a proven tool to compare the performance of the individuals. Timelines, as we talked much about the timelines, you've seen like how effective the timelines are important, very much important in the STEMI care. Like we have seen right from the patient actually coming to the ER till the patient was taken into the cardiac catheterization lab. The timelines were very much important in defining it, and how quality measures were important in timelines also we will see. So it will give you an opportunity for you to identify further like opportunities in the improvement, like to identify what are the bottlenecks in the processes. So overall, in a nutshell, like this quality metrics, not only in institutions, overall in a community, which we can definitely help in improving the overall outcome of the care. So let's see like how we can build up this entire framework for the quality improvement program. So the first and foremost is you should have some of the quality improvement initiatives to be driven in the organization. And you should develop your own metrics, quality metrics, and you should have a multidisciplinary collaboration with the teams, like as we have seen the right range of clinicians who are participating in this STEMI care. And the standardized protocols called clinical pathways. Quality improvement initiatives. One is, as Dr. Malay Mishra sir has said, like a code STEMI. One at institutional level, another is community level. Having a code STEMI, like having a proper process flow, right from the patient's arrival from the ER and ED triage, and assessing the patient's signs and symptoms, and diagnosis, and intimating communication to the cardiologist, and patient was taken into the cardiac catheterization lab for the PCA. So fragmenting the care, okay, having a process flow and implementing this code STEMI will definitely give good results in the outcome of the care. Another one is, like, if you see sharply, there are many articles which are published and proven like evidences saying that having this code STEMI has almost reduce the time for almost double the time. Like if you see the institutions who have implemented this code STEMI have taken up these patients within 90 minutes of ER arrival. And those who don't have these protocols and code STEMI implemented, it has taken almost more than 3 hours of time. So this is one good model which we have studied at India. There is a pilot which is done, pilot study in Tamil Nadu, which is talking about how this STEMI care can be improved at community level. This is called hub and spoke model. If you see here, there is a hub which is PCA capable, and there are like D and C capable institutions, like there are primary institutions, and these are all like small healthcare setups. So if you see this PCA capable is how these are connected to the other healthcare facilities. If you can see, there are many times if you see the patients end up with D and again coming to C. So there is a lot of actually important time we will be wasting at this stage. Having this network, actually you can actually direct the patients right from the D to directly A. So this is how there are multi-centric studies which have been done in Tamil Nadu, and it has improved a lot of actually improvement in the giving a STEMI care. So what all quality metrics we can see? I can say like this quality metric should encompass throughout the patient clinical course, right from the patient entry to ER till the patient discharge. So what at the time of STEMI onset, so what measures we can consider is like total ischemic time. When the patient had the chest pain, total ischemic time we can consider. What all interventions we can have. We can bring a lot of awareness among the public. So this is one aspect like which currently our country is lacking. And having an emergency activation systems. Okay, like 108, even in Yashoda, like 105910. So having these emergency activation systems, which definitely actually improve this stage. The next stage is about EMS activation. EMS activation right from the patient entry into the ER. So what are the patient measures we can see? FMT to be like first medical contact to balloon time. There are institutions which actually drive right from the when you receive a call, like they send the rapid action team, and right from the first medical call, medical contact with balloon time, they capture measures. So what are the interventions can be issued? Like as we have seen in the earlier presentations, like pre-hospital ECG. Pre-hospital ECG will definitely actually improve a care delivery and bypass non-PCA capable hospital. In the previous slide, I have seen like there are a network of hospitals which are not PCA capable. So with this EMS activation at having these measures, the first medical contact to balloon time, we can actually bypass non-PCA capable hospitals, and even sometimes we can directly land up the patient at CCL, like cardiac catheterization laboratory, pre-hospital activation of CCLs. Then moving on, patient arrived at ER, ED arrival, what all medicines? Like majorly, like most of the institutions will follow, like so door to electrocardiogram time, ECG time, and door to balloon time, and door to needle time, and door in to door out time. There are certain institutions like which are not PCA capable. So what measure they can consider is when the patient has come to their facility and when the patient has left their facility to another PCA capable facility. So they can capture DI, DO. So what all interventions are important, like pre-hospital ECG interpretation, dedicated chest pain triage, and CCL activation from the ER physician, by the ER physician. So CCL activation at the and PCI. So what all measures to be considered? Like door to balloon time. Interventions, as I mentioned, pre-hospital CC activation, and you can bypass even ER. Sometimes you can patient when you have a first medical contact at emergency services, you can bypass even ER, and you can directly patient can land up at CCL laboratory. and if you have an on-site cardiology coverage. Most importantly, most of the institutions which ignore is discharge stage. So discharge stage, what all measures can be considered? You should have a guideline directed treatment prescription, because you have seen the treatment which is given by various clinicians which are not actually not uniform, like because of not having clinical pathways and clinical protocols established. So this guideline directed treatment prescription which definitely have an improvement in the post discharge care and evaluation of ejection fraction and cardiac rehabilitation referral. So what all interventions you can follow up, like the post discharge follow up. Very few institutions will take up this post discharge follow up, and having a clinical pathways and protocols, and at the time of discharge, and having a patient and family education. So to summarize all these metrics, what are the widely used in quality metrics in STEMI? So as I mentioned, I have segregated them into three actually stages. One is pre-hospital process, hospital process, and the post-discharge. So one, the pre-hospital process is door in and door out time. This is DIDO, which I mentioned. The time the patient presentation to patient leaving to the ER in a transfer to a PCA capable center. So there you can consider having this measure called DIDO. So the benchmark which is less than 30 minutes. And the next quality metric which you can consider for the in-hospital processes is door to electrocardiogram time, the time between the patient's arrival and the performance of ECG. So this should be less than 30, this should be less than 10 minutes. When the patient has come to the ER and when you have taken an ECG, it should be less than 10 minutes. Door to balloon time, this is also an in-hospital process indicator where you have seen the time between the patient arrival or from the EMS to the initiation of balloon for angioplasty or PCI. It should be less than 90 minutes. So other indicator is like door to needle time. It is also an in-hospital process indicator where you can see the patient's the time of arrival at the ER from the initiation of a fibrinolytic therapy like thrombolysis. This improves patient outcomes and lower the mortality rate. Like benchmark, what we can see is less than 30 minutes from the patient arrival at the ED. So there are certain indicators which we can monitor is readmission rate. Readmission rate, like at what rate patients are getting readmitted for a certain period of time with the same complaints. So this also can be captured, this benchmark as per the hospital policy. Another like interesting thing which we can monitor as a quality metric is acute EA, patient with acute EA after 30-day mortality. Like what is the mortality rate? What is the clinical outcome? This will look at the clinical outcome. So I don't think so. Like very few hospitals like which are JCA accredited, which JCA mandates them to actually publish this data online. So they have to mandatorily publish this mortality rate, outcome, clinical outcomes in their website. So the benchmark as per the guidelines is it should be 5 to 8%. So what are strategies you can implement for developing these quality metrics? So one is most important thing is baseline data. You should have a baseline data. Most of the times we start programs and we end up actually not having any data to monitor these programs in an objective way. So what is most important here is having a baseline data. So how can you have this baseline data? Never, I strongly suggest not to have any other mediums to collect this data at time intervals. Try incorporating them into your care pathway. So we have established at our Yashoda Hospital, we have this ACS pathway where you have seen like most of the time intervals, what I have mentioned to capture this quality metrics are already being actually captured in this process. If you see date and time of patient arrival, and even if you can see like whether the previous patient had any previous visit, like we can see like readmission rate also, and you can see what the time the patient has taken ECG. So with this information, you can try collecting the baseline data, which is useful for measuring the quality metrics. So some of the time we can take even the data from the PACS. So this is how you need to define before defining your quality metrics in advance and where all I wanted to capture this information. Another strategy is having a process mapping. This is the most important step actually in the most of the programs, most of the institutions they miss. So how can you do this process mapping? You can shadow a patient. You can shadow like 5 to 10 patients. You can shadow a patient right from the patient entry till the patient is sent into the cath lab. So where you can understand what are the bottlenecks of your entire processes. If you see right from the patient entry from ER, you see a lot of touch points you can see with the various number of hospital processes and hospital staff also. So once you shadow this like patient journey, you will understand what is the process flow and where are the bottlenecks. So most importantly, what approach you can adopt here is RCA. It is not right coronary artery. There are similar terminologies which you can see because right coronary artery. Here it is root cause analysis. Root cause analysis. This is a like widely adopted approach for conducting a root cause analysis to understand what are the bottlenecks, what are the issues, what are the important issues with your processes. So just an example here, there is a delay in door to balloon time. You can actually plot this actually chart either with 5Ps and 5Ms. So you see like what are the issues with my materials? Are there issues with my policies? Are any issues with my personnel? So you can narrow it down like what are my issues so that you can work on improve the process flow. So another important approach is having a multidisciplinary approach. So here is interdisciplinary team. You see like you will be handling many complex cases where you require interdisciplinary treatment approach, where you require support from other clinicians also. And in hospital, multidisciplinary teams. So as I mentioned, like right from the ER till discharge, you will encounter with many of the hospital staff, right from physicians, nurses, rehabilitation therapists. So you should have an interdisciplinary approach. So it is overall, it will improve your efficacy and improve efficacy. Like another approach is having a standardized clinical pathways. Very few hospitals we have because the accreditation bodies like NABH and JCA, those have been actually mandated this having these clinical pathways. Apart from that, if you see 80 to 90% of the hospitals are not adopted, have not adopted any clinical pathways. So what is the use of having these clinical pathways, standardized protocols? So which will actually provide you evidence-based key interventions, and it should be across professional groups. We have seen many a times these standard protocols or clinical pathways were done only at the ER level, sometimes only at the ICU level. So the clinical pathway should encompass right from the entry till the discharge of the patients so that overall care can be assessed. So that it improves your overall communication and coordination. If you see the clinical pathway, it will improve the overall communication right from the patient entry into ER, the patient was taken into the cath lab, and how the patient was actually treated at ICU, how the discharge. Overall, you can summarize in this standardized protocols. So once you are done with setting up like your quality metrics for your entire STEMI program, so most important part is having a monitoring of your QA processes and outcomes. So one important step here is having a permanent STEMI QA infrastructure. So what is important here? So having a dedicated leadership so to drive this entire program, integrating technology, as I have seen in the earlier presentations, like having digital ECGs, like having an AI incorporated into this STEMI care can improve this entire QA infrastructure. So ultimately, like should have the high quality data to actually objectively say that you have improved your care outcomes. And ultimately, you should have quality improvement teams. So public reporting is another important process because, as I mentioned, as apart from the as it is mandated by accreditation bodies, so even you have to publicly report some of the data. So that will actually enhances your like how you are performing well with your other P group like other organizations. And there are like I think it is there in this developed countries like US. So your performance is actually graded based upon the outcomes. And you will be emphasized, even the clinicians are incentivized based upon the outcomes, which is published in the websites. So this public reporting definitely will help in encouraging and improve care processes. So what else is like you should have an MMN committees like mortality and morbidity committees to be established. So this is one platform where you can explore this patient, provider, and institution factors, like where we went wrong. Probably you can take up some cases like which have went wrong and study in this mortality committees where you have this interdisciplinary team will be gathering together and discussing on these cases. So mostly these MMM committees are useful in analyzing the performance and system factors. Are there any system level actually issues are there? So evidence-based QA framework, like this is a widely approached a quality improvement model, which is invented by Deming. So this is called PDSA or PDCA. So as I said, like you should have a continual quality improvement program. You should analyze like how well you are doing your care delivery, like analyzing your overall performance over a period of time, like check. So planning your thing and acting on things, study like whether you are doing well it or not, and try to actually revise your concepts and processes. So how are we going to translate these strategies into actions? So one most important thing is to address the gaps in care and reduces variation and optimize patient outcomes. So another thing what you can achieve by adopting these quality metrics is promote accountability and transparency in STEMI care and enabling benchmarking and comparison of performance across healthcare organizations. The next is it can help identify potential risks and drive interventions to improve overall patient safety. This is what the ultimate goal of actually any quality improvement program. So having said that, he's a famous we can consider him as a father of modern business management. He said, if you cannot measure it, you cannot manage anything. Like unless and until you start measuring things, you cannot manage your processes. So with this, I'll end my presentation and thank you so much for your patience listening.
Mr. Kiran, for giving us this wonderful, exhaustive presentation on quality. I think we have Dr. Sadanand Shetty waiting from Mumbai. He is my good friend. He is the Vice President of the Lipid Association of India. Are we going to connect him or ready?
I'm
Are we
already
ready?
online, Raghu. Yeah.
Yeah, Dr. Sadanand Shetty is the Vice President of the Lipid Association of India, and he runs a very active contemporary training, teaching. He runs a platform on the WhatsApp, which includes almost, I think, about 2,500 cardiologists across the country, two groups of WhatsApp, excellent daily summarizing of the information, various latest clinical trials and all that. I thought I should involve him as a part of this program, but he has today ACC Sky Next program in Mumbai, so he could not come here, but I requested him to present on lipid lowering therapy in acute coronary syndrome. Thank you, Dr. Sadanand Shetty, for honoring our request, and we are grateful for your presence here. Thank you, Dr. Sadanand.
Just few minutes ago, there is some, just 1 minute technical, I will just solve it,
Solve something.
Till that time, you just see the.
Yes.
You can discuss the previous, just few minutes. Yeah. Okay.
We had Dr. Kiran, Mr. Kiran, who was presenting about the quality improvement metrics in our practice. They are of essential use. For example, somebody might be running a single doctor center. The importance of implementing the quality metrics is you will have a team to address the issue. Otherwise, what will happen is only the doctor will be trying to bring about the process change and nobody is a stakeholder. We have so many stakeholders who find themselves empowered as well as responsible for carrying out these time frames, timelines and all those things. It's impossible for us. Otherwise, you will get, the clinician will get exacerbated by the process delays and time delays. Sometimes the delay will be from some simple things like, for example, acute myocardial infarction, angiography done, patient is lying on the table, decision not taken by the family. If we have a proper educational framework so that, look, if you delay beyond 90 minutes, you are going to die faster, take a decision immediately. So all will come with a proper educational material also. Without the educational material, without involving multiple stakeholders, I think quality metrics is very important. I still, 4-5 months ago, we had the NABH award for the cardiology team. The first question what they were asked is, what are the quality metrics you employ in the cardiac cath lab? To the nurses. So the nurses should be aware of what are the quality metrics. Otherwise, if they are, the doctor is only bothered about door to balloon time, I think that is going to fail miserably.
Hospital. You can see my slide. You can see my slide, Raghu.
Yeah.
Yes. Could you see my slide?
Dr. Sadanand.
You can see my slide.
We can see your slide and we can hear you also.
So can I start?
Yes, sir. Please
Yeah.
start.
Yeah. Thank you, Yashoda Hospital, and in particular, Dr. Raghu. Of course, Dr. Raghu has requested to be physically present at Hyderabad, but due to some logistic, I could not make it. So what I'm going to do for the next 15 minutes or so is to talk about why lipid-lowering therapy in acute coronary syndrome is an important topic. All of us know that acute coronary syndrome represents a constellation of events. You know,
श्री रामचंद्र जी महाराज के भरे दरबार में विभीषण के गाना मारा।
some shadows are coming.
हनुमान जी ने श्री राम का नाम लिया और सीना फाड़ा, बोले लेते।
Can you hear me, or the slide is?
जी जी समझिए, कृपया जीजे के सामने से हट जाए।
Slide. Some disturbance in the slide.
Some disturbance in the slide.
There is some, yeah.
There is something else.
This is due to some technical reason, or?
I think we need to Zoom. Disabled. Yeah.
Can you?
I think possibly you can log off and re-log in, sir.
Should I do again? Yeah.
Yeah. We will do some other stuff.
Can you see here?
Yes, sir.
You can see here?
Yes, sir.
Yeah. So why this topic is important? There are some disturbances.
Something is happening in the background, and we are getting.
सर बिल्लो बक्के बिल्लियां की करेंगी?
Yo.
Anything particular, or?
No, something is happening. Something is happening, and I think we need to log off all the rest of the people on this.
Hello.
Yeah. Anyway, I will try to.
Can do is where is our girl? Saraswati, did you download the slides?
No, we didn't, because in our LA policy, they don't want to share the slide, yeah. So that was a little technical.
Hello, sir. Can you hear me? Hello.
Yeah.
Yes. Who is it?
Sir, actually, I am speaking from Zoom helpline. सर आपकी जो ये क्लास है इसको कुछ हैकर्स ने सर जी हैक कर लिया है, तो आपसे मेरी हम्बल रिक्वेस्ट है, आप इस लिंक को आप बंद कर दो, आप दूसरा लिंक शेयर कर लीजिए।
Okay.
जी, आप इस क्लास को आप एंड कर दीजिए सर।
Yeah, something else.
Another link you are going to take?
More very powerful hackers. I think we need to share another Zoom link. Yeah.
Okay. I don't know Sari, what's her name? Whether she's got my email or.
No. I think the Zoom link has been shared publicly, so somebody must have hacked the Zoom link.
Okay, so now.
Disable करके फिर से एक लिंक सर को भेजो तो 1 minute में अब you can send one more link only for the presentation sake.
But in the same, I should remain here only?
Sir, I think what I can suggest you, sir, is if you can send the slide set only as a one-time this one because of hacker.
Oh, is it? So
सर आपकी क्लास में सर आपकी इस मीटिंग में काफी सारे हैकर्स आ चुके हैं, आप प्लीज जल्दी से जल्दी इस मीटिंग को एंड कर दीजिए।
What is it?